kg, we can use Tafet, and we can use as well as TLD for those that are more than 30 kgs. I'm not sure if this is the last slide or we have another slide. Next. So I think we have another situation that actually we will meet every so often in our practice and care, and that is co-infection with TB. We know that most of the TB drugs tend to have interactions with ARVs, and indeed DTG interacts with TB medicine, the rifampicin group of drugs. And so children aged more than 6 years and weighing 20 kg receiving TB treatment, according to WHO, it's recommended that you double the DTG dose for the duration of the TB treatment. 1 dose in the morning and 1 dose in the evening. Bernard, we request you mute yourself. Thank you for joining us, but kindly mute yourself. This has been evaluated on the ongoing Odyssey trial and demonstrated to be safe in children more than 6 years and less than 20 kg. For children who are less than 6 years, MOH has recommended that we do also double the dose for those children less than 6 years who have TB, and we enhance pharmacovigilance and clinical monitoring during this time that they'll be on TB treatment. But as soon as the TB treatment is done, we switch them back to the standard OD dose. Thank you so much. I hope that has been very clear and helpful for us. Dr. Zimba.
Thank you, Dr. Jambo. So before we let you go, we have this poll question. Poll question number 1 again. So which of the following is not true regarding pediatric DTG? A, it has better side effects profile and improved tolerability over lopinavir. B, eligible for children who are at least no, Chatonda, I think we've given poll question number 2. We should go back to 1. We ended it, so we can start with 2. Thank you. So we're saying B is eligible for children who are at least 4 weeks of age and weigh at least 3 to 20 kgs. C, dose of pediatric DTG should be doubled in TB HIV infection. And D, none of the above. So the question is, which of the following is not true regarding pediatric DTG? So we're picking what is not true. I think out of 417 participants, we have at least 150 that have polled. That's quite good attendance. We can continue polling. We have about 20 seconds to go. We are at 50%. Okay, so I think we'll stop when we are 65% at least of the audience polling. And it's not stopping that we just want to stop, it's in the interest of time. So thank you. So we have at least 170 people that have polled, and we can stop and share the results. At least the majority of our participants, 125%. Is it out of 125%? Something wrong. 240 of the participants. We have 470, 27 on the call. I think D is the correct answer. I think Dr. Ziambo, you've done a good job. At least the majority of the participants have picked that D is the best answer. We have a question for you in the chat, Dr. Ziambo. I've just seen there's a question, I think, coming from Simasiku Namasiku. that pediatric DTG interacts with TB drugs, how do we administer it to children on TPT? Would you take that question, Dr. Zambo? Dr. Zambo?
Apologies, Dr. Zimba, we lost our internet.
Okay, so there's a question on interaction of DTG with TPT. What is the guidance?
It's a very, very interesting question. TPT, so I think we have two options for TPT, and I think one of them, there's the 3HP, and then we have the INH and the rifampicin one. So I think in these circumstances, we will probably have to take the option of the 3HP. I'm not too sure. There's no interaction.
Thank you. So
maybe let's hear from Dr. Sombo. I'm with Dr. Sombo and I'm with Mukumbi here. So maybe we can hear from them.
Thank you. Please go ahead.
Dr. Zimba, are you able to hear me?
You're too far from the mic, please.
I'm so sorry. I just jumped in here. Good morning, everyone. I think that's very interesting. So, I think you all agree TPT is broad and many options of which some of them.
We can't hear you, Dr. Sombo.
I'm very close. Can you hear me now? Hello?
Okay, better.
Or maybe it's just me. I said that's a very good morning, everyone. So TPT is very broad. So when you're using dolutegravir, it depends on what TPT you use. Of course, we do not expect any interaction between isoniazid and the dolutegravir. We do not expect any interaction between rifampicin and dolutegravir. So those are your options. When you use 2HP, that's rifampicin and not rifampicin. They're in the same group, which is the rifamycin. The worst rifamycin when it comes to interaction is rifampicin, which is an option but not commonly used if you want to use rifampicin with isoniazid. So for now, I think it's safe to say that we do not expect any interaction with isoniazid and the rifampicin. So
we can't hear Madam Mukumbi.
Okay, so Dr. Foloshi, unfortunately, we can't get you very clearly, but the summary of what Dr. Foloshi is saying is that the DTG does not interact with our main PT backbones that we're using in the HIV population. We're using isoniazid and rifampicin, so they're safe to give, and DTG won't interact, so we are very much okay. If we're using a rifampicin-based regimen, then there is the interaction for TPT. So we are not using the rifampicin isoniazid in our pediatric population. So Dr. Ziambo, there was a hand up for you. I think we can take one hand before we move on. Time. There was a hand from Hilda.
Yeah.
Hilda, is your hand still up? Please go ahead. Okay, Mwale, go ahead.
Where's the mic?
Okay. Mwale hasn't unmuted themselves. Shirungu, please go ahead.
Thank you so much, This is Tashi Lungu.
Go ahead.
I was muted. Hello?
Yes, go ahead.
Yes, I'm saying thank you so much. This is Tashi Lungu, Pediatrics and Adolescent Coordinator from Northwestern Province. This is really a milestone that we have achieved, and I would want to thank the team for the efforts that have been made for us to have this DTG for pediatrics. I would really want to get clarity when it comes to unsuppressed peds and pediatric DTG. Speaking from the experience, what we are seeing on the ground is the issues of adherence are not really that they don't want to take, or the caretakers don't want to give the children the drugs, but they are looking at the issue of frequency. And so you find that our children are unsuppressed, not really because it's the adherence to taking the drug itself, but it's the issue of the frequency and the like. So we know to a certain extent that if we are to give these our children something that is a once off every day, it's something that is going to improve. And most of our children are unsuppressed because of that kind of scenario. So I would really want to get clarity on how best we can help them switch to an OD kind of regimen, which we know for sure that if we put them on this, the suppression levels will go up. So Dr. Ziambo, I would just want you to clarify really how we are going to handle our unsuppressed pediatrics, because they don't necessarily need to be switched to second line. It's something that really needs to be worked on within the first line. But how are we going to go about that? I just wanted some clarity on that from Dr. Ziambo. Thank you.
Does Jambo take that question, then we can move on.
And
Dr. Ziambo, there's a problem with the mic, I think, where you are. We are unable to get you.
can you hear me now?
Faintly, but better.
Yeah? Better. I don't know what is happening. At the same settings I was using when I was presenting. Can you still hear me?
Yeah, better now. Yes.
Okay. I was saying that those concerns are very genuine, and we know the process that we use when we are establishing failure, treatment failure. So not every unsuppressed child has a treatment failure, and we know that. And during that counseling process, we do identify the barriers to what has led to poor adherence. Once we identify the barriers to what had led to poor adherence, we will know that they just have not been taking the drugs. And that makes it very safe for us to be able to transition them to a simpler regimen, which is DTG. So in that case, it makes it even easier. So, and we actually, you and me are actually speaking the same language, but I just want, maybe we just keep in mind to say, when we want to establish treatment failure, we'll run through the adherence process, and then we will know from the adherence process what exactly is causing them to be unsuppressed. There are some things that you can address when you establish what is causing the unsuppression. And some of those might be the way they're not just taking sufficiently. And once they take sufficiently, they'll suppress. So it's just the whole process of establishing what is causing the unsuppression. I think that's the emphasis. If we establish that what is causing the unsuppression is the drug, then that means we are now moving on to the second line. But if what is causing unsuppression is suboptimal doses, suboptimal not taking, then we address that by giving the pDTG, which is easier to take. I hope that is much clearer in terms of the process of transitioning. Thank you.
So thank you very much, Dr. Ziambo. I think in the interest of time, we will keep addressing some of the concerns in the chat. You've really addressed and brought in the importance of us bringing in pediatric DTG to this population. So we are saying for all children 4 weeks and above who are 3 kgs and above are eligible to get a DTG-based regimen. So in that interest of time, thank you for that presentation. We'll proceed with Ms. Mukumbi Kabesha to give us the next on communicating and counseling. Please, the floor is yours. Mukumbi, I think, is a pharmacist at UTH Pediatric Center of Excellence, and will take us through this. Please go ahead.
Thank you, Dr. Zimba. Good morning, everyone. Am I loud and clear?
Yes, you are.
Okay, thank you. So
We can get you.
I'm going to take you through communication and counseling, and I'll be later joined by my colleague from Livingstone, Ms. Jean Kavanda. So just to lay a quick background, as we are communicating to these caregivers, we have to bear in mind where we're coming from, okay? So first of all, our first objective is to describe the counseling process, how to administer. We also have to explain, okay, counseling tips, explain how to administer the pDTG alone, as well as with the other drugs, namely ABC and 3TC. Next slide, please. Okay, so I'll hand over to Dr. Zimba to take us through the 4 questions.
So thank you very much. So we have question number 2. So we're saying the following are true. The following are true counseling points when transitioning clients to pediatric DTG, except A, encourage caregivers to ask questions. B, child should drink all dissolved meals within an hour. C, pediatric DTG can be dispersed together with ABC 3TC 120 60 milligrams. D, use other liquids such as juice, milk, yogurt, porridge if child is unable to take pediatric DTG in water. We can run the poll, Chatonda. Okay, so that's good, but at least the number of polling is increasing. We are at 10%. We have 447 connections. About 70 have polled so far, which is quite good and encouraging. So the following are true counseling points when transitioning clients to pediatric DTG, except A, encourage caregivers to ask questions. B, child should drink all dissolved meals within an hour. C, pediatric DTG can be dispersed together with ABC 3TC 120 60 milligrams. D, use of other liquids such as juice, milk, yogurt, porridge, if the child is unable to take pDTG in water. So majority of our participants think D is not the correct one among those. So we are at 1 minute, 10 seconds of polling. We'll just give another 15 seconds. Please, you can poll. We are 39% of the people on the call polling. It doesn't show names. You just poll. We just see the percent, the number per polling. Don't feel ashamed to poll. My son says getting it wrong means you are trying. So we should all try. Okay. So yeah, just a few more to poll. So at least we have 50% of the participants polling. Okay, so thank you. We see that about 90%, 90 people 98 people thought D was not the correct answer. So Mkumbi will take us through the next slides and we see whether our thought was correct. Over to you, Mkumbi.
Thank you. Okay, so I was saying, before we define communication and talk about what it entails, just to set a background, remember that these are caregivers we're dealing with. We started some of these children on Calitra. So we gave these children a bitter syrup, which was difficult to measure for the caregivers. It was difficult to store because it required refrigeration and left an aftertaste. And then after some time, we introduced the granules and we told them that there's good news for them. We're introducing a better product. They were very expectant, and we still had challenges with the granules, like Dr. Mutali mentioned. So we thought that they would be more palatable, but they were quite difficult to take. And on top of that, they were also very bulky, so difficult to carry as well. So as we introduce this product, let's bear in mind that some of these caregivers may be a little bit skeptical. Us as healthcare workers are very excited because we know the benefits of pDTG. We know how easy it is to give. We know that it tastes better, it's easy to administer, but we may have a little bit of a challenge convincing these caregivers. Okay, so that's the background to that. So as we go into communication, we do know that communication is the process of exchanging information, thoughts, feelings, ideas, instructions, and knowledge. So here we're underlining exchanging. So it's not a one-way process. It's us as the healthcare givers talking to the clients, caregivers, and them giving us feedback. And so the first thing we have to do when we're counseling is to establish a relationship with these caregivers. And as we're doing that, we need to gain their trust by giving them correct and appropriate information so that they're able to make an informed decision. And there are certain techniques that we use that will make our counseling effective. And one of them is using open-ended questions. That way, they're able to give us more answers as opposed to a yes or a no answer. We also need to affirm our caregivers. We know that pediatric administration of drugs is challenging, and where they're doing well, we need to encourage them and affirm them. And we also have to listen reflectively. And when we're done with our session, we should be able to summarize with our statements at the end. Next slide, please. Okay, so some good counseling and communication skills are very essential because without those, we'll not be able to relay the information. We may end up talking to ourselves. So one of them is to make eye contact with the patient. As you look at in this case, it may not be the patient, it may be the caregiver, but let's also acknowledge our patients as well. You know, we often overlook children and we talk at them, we talk over them, but we don't talk to them. So even if we're talking to the caregiver, let's just find time to make eye contact with the child. With this COVID-19 and wearing of masks, it's very difficult for our children to know that we're smiling at them. So we can always even give them a thumbs up sign or just wave at them, just so that they know that we're concerned about them and want to engage them. And it's also important where we can to sit face to face. And as we're speaking, let's speak clearly. Let's avoid technical terms. Let's avoid jargon. Let's use plain language. And also let's use a non-threatening voice. We should not be judgmental and we should be respectful without blaming or criticizing. Like one of the questions that came up, some of our caregivers have got challenges administering drugs twice a day. So we should not blame them or criticize them, but let's acknowledge that it's not easy to administer medication. So I talked about open-ended questions. So these will allow an answer that is not yes or no. So we just have a few examples of these questions. We can say what makes it difficult for your child to take his or her ARVs every day. Or we can say, what have you already done to help your child take their medication? Or what do you think is likely to happen if your child keeps taking ARVs as she or he is doing so now? Next slide, please. Okay, I also talked about the importance of affirming. So by affirming somebody, we're offering them emotional support and we're encouraging them. So one of the statements we could use is to say, I appreciate that you can be honest about the way your child takes his or her ARVs. And where people have used tips to remind themselves or ways of administering medication, we can affirm them by saying, oh, you're clearly a resourceful person to manage so many challenges. Let's remember that some of these caregivers have got more than one child on treatment, and some of these children are taking different medications. Some of them are school going, some are not school going, so they really have to work around that. Another example is you've worked hard to help your child take his or her medication despite these challenges. So when we affirm somebody, it makes them they're more likely to open up and mention the challenges they're having. When we talk about reflective listening, you're listening in such a way that you're understanding what the person says and what he or she feels. So examples of some questions would be, you say you feel frustrated when your child refuses to take ARVs, is that correct? Or you can say, oh, so you feel anxious about being able to take or give your child ARVs at the same time every day, is that correct? Or you can say, what I hear you saying is that you have so many other important things to do. It can be difficult to spend so much time giving your child ARVs. Is that correct? And that's one thing that we got from people giving the sachets, the granules. Because for those who are taking, say, up to 5 sachets in one dose, you cannot give all 5 at once because it will be too much for the child to take. So they have to take one at a time, and it can be quite lengthy. So at the end of your counseling session, you should be able to give some summary statements. So that's going over the main points that you've discussed with your client. So for example, you can say, let me see, if I understand so far, you want your child to be healthy, but you're struggling to give your ARVs because of time, or you often don't have food or other things that you need to give the way you've been told to do so. Okay, we can proceed. So these are just examples. We can proceed to the next slide, please. Okay, so at this point, I hope Jean is on the call. I'm going to hand over to Jean from Livingstone to take us through the actual administration process. Jean, over to you.
Thank you very much. Good morning, everyone. My name is Jean Mukumbuta from Livingstone Teaching Hospital. I'm an ART pharmacist. So I'll take you through the administration of pediatric DTG with clean water. So pediatric DTG 10 milligrams, just as it has been explained already, is a cold dispersible tablet. This dispersible formulation allows pediatric DTG to be easily administered to the children, that is by dispersing water, rather than having to swallow multiple pills or other pellets and the granule formulations, which have been a huge challenge for our caregivers. So this pediatric DTG 10 milligrams cold tablet allows the tablet to be broken evenly and therefore provides an optimal dosing for our children. So we'll do the further demonstration at the end of the presentation. Next slide, please. Next slide, please. So we continue with the administration of pediatric 10 milligrams cold tablet with clean water. So it's very important that our caregivers are well guided on how to administer this pediatric 10 milligrams tablet. So our caregivers should be guided to add the appropriate dose for weight of the pediatric DTG to clean water. That is by stirring until the tablets dissolves and administer it to the child. So we need to take note that when dispersing 0.5, that is half a tablet, or 1.5, that is 1.5 tablets of DTG 10 milligrams, this has to be dissolved in 5 ml of water. That is 1 teaspoon of clean water. That is what should be used. And when we are dispersing 2 tablets, or that is 2.5 tablets, for those children that are weighing between 14 kgs and 19.9 kgs, we need to take note of the difference. We have to ensure the client, the caregiver understands that we need to dissolve it in 10 ml of water. That is 2 teaspoons of water. So even when we are explaining to our caregivers in our various facilities, we are dealing with different types of caregivers. There are some caregivers who easily understand, and there are those that take time to understand. So we really need to ensure our caregivers understand this administration of the DTG 10 milligrams. For those who are supposed to take a dose of 0.5 milligrams for 1.5 tablets, the tablets should be dissolved in 5 ml of water. And for those that are taking 2 tablets or 2.5 tablets, we need to ensure the caregiver understands that this tablet should be dissolved in 10 ml of water. That is 2 teaspoons of water. So if the medicine remains in the cup, we need to ensure we inform our caregivers that they will need to add a small amount of additional water to the cup, swill, and give the child. So there are times where maybe the child vomits the medicine. So in such cases, we need to repeat that dose. And then we should also ensure that the child drinks all the water straight away, or rather within 30 minutes. So from our experiences, there are some children who are able to drink their medications, like, sorry, may I have the previous slide? Hello? Okay, so yes, so I was on the last point. So here we really need to ensure our caregivers understand that the child should drink all the water straight away, or they try as much as possible to give within 30 minutes. Thank you. Next slide. Next slide, please. Next slide, please. Thank you very much. So this takes me to the co-administration of Abacavir, lamivudine 120/60 milligrams, together with the DTG 10 milligrams. So the question is, can ABC3TC 120/60 milligrams be administered together with the DTG scored 10 milligrams tablet? So the pediatric DTG 10 milligrams scored tablet can be dispensed and administered in the same solution of clean water as the Abacavir lamivudine 120/60 milligrams. So we need to take note here that when dispensing both products together, we use 10 to 20 ml of water. That is about 2 to 4 teaspoons of clean water and ensure both medicines are properly dissolved before administering. So if dissolved, if not dissolved well, let's say we don't add the recommended water, lumping occurs. Lumping occurs, and the lumping is just basically the accumulation of a piece of mass. It can be a solid matter without regular shape, and if such an occasion happens, we need to ensure we counsel our caregivers to ensure that they steer slowly by adding water until everything dissolves. Next slide, please. Next slide. Next slide, please. So this takes me now to the use of different types of media for dispensing our pediatric pDTG 10 milligrams. So here we should note that our pediatric pDTG 10 milligram scored tablet is a dispersible tablet and should ideally be dispensed in clean water or swallowed raw. Use other liquids. You can use other liquids such as juice, milk, yogurt, porridge. That is, if the child is unable to take pediatric pDTG 10 milligrams with water, just like the way we've been doing for our granules. So with our granules, we are able to advise our client, our caregivers to mix the granules with the liquids or foods that the child likes. So even in this case, where a child is unable to take this pediatric 10 milligrams tablet in water, we can talk to our caregivers, counsel them, and inform them that foods such as juice, milk, yogurt, porridge can still be used. So if the pediatric pDTG 10 milligrams is mixed with other foods or liquids, here we need to ensure that the child consumes the entire amount of liquid or the food that this drug is mixed with. So this point, the last point, is very, very important. So we need to ensure, even as our caregiver leaves our facilities, that they have understood these instructions. Next slide, please. Next slide. Next slide. Thank you very much. These are just counseling job aids for treatment of naive and experienced recipients of care. So these job aids will be circulated to the various facilities. This is just to help us, the caregivers, to understand more about this new pediatric 10 milligrams dispensed scored tablets. So these job aids, the counseling job aids, will be shared with the various facilities. Thank you. Next slide. The same for this page. These are just materials explaining on the DTG 10 milligrams, just giving us more information as caregivers, even as we give our counseling to our clients. Next slide. So these are still materials, that is posters and booklets that will be used. I saw a question in the chat. Someone was asking about the videos and the posters. So this information will be facilitated so that we learn more about our DTG pediatric 10 milligrams. So our take-home points are to ensure that our clients understand the administration of this pediatric DTG milligrams. So the pediatric DTG 10 milligrams tab can be easily administered to the children, that is by dispensing and drinking the medicine in a small amount of, can be administered using other liquids, that is juice, milk, yogurt, and porridge. And the child should drink all the water or finish all the food used to mix the pediatric DTG scored milligram tablets. Thank you very much. Thank you very much for listening. Over to you, Dr. Zimba.
Thank you, Jean. Thank you, Jean and Mukumbi, for that presentation. I think our questions in the chat are being addressed. Those who have burning questions, please hold on to them. We'll address them as we do the question and answer session later on in a few minutes' time. We'll go straight into our poll, and then Mr. Kampamba and Ms. Monze, be ready for the next presentation so that we can catch up with time. So our poll question number 2 is just to try and see that we've all gotten something from the presentation that Ms. Mukumbi and Jean have just given us. So it reads, the following are true counseling points when transitioning clients to pediatric DTG, except A, encourage caregivers to ask questions. Child should drink all dissolved meds within 1 hour. C, pediatric DTG can be dispersed together with ABC3TC12060. D, use other liquids stroke foods such as juice, milk, yogurt, or porridge if child is unable to take pediatric DTG in water. Okay, so we'll give a good 45 seconds for this poll to be done. Okay, this is impressive. We can see that people have not changed their minds from the previous answers that they were giving, and shows that Jean and Mukumbi have done a good job in making the participants see what is there. So 89% of our participants believe that B is the best answer. I think in the presentation we had said 30 minutes. So it's the correct answer. So we'll quickly go on to session 3. Please go ahead. And then courtesy is that we should mute our mics and videos if we're not the ones speaking, so that we make the presentations flow and other people understand. So thank you very much. Mr. Kampamba, you can please go ahead.
Okay, thank you very much, Chair, and riding on the protocols that have been mentioned before me. So good morning once again, everyone, and welcome, of course, to this session to do with the supply chain for the pediatric DTG 10 milligrams. Next slide, please. So, of course, this is what we expect people to know or should be able to describe the supply of pediatric DTG to the various health facilities across the country. Of course, selected facilities, and we describe the handling and storage of this commodity, pediatric DTG 10 milligrams. Over to you, Chair.
All right, so thank you. So we'll go to poll question number 3. Which of the following is not true about pediatric DTG? A, the bottles in the country are not, the bottles in the country are not child resistant and should be stored safely. B, the bottles do not need to be stored in a fridge. C, no need to report and request the pediatric DTG because it will be distributed with a push system. D, pediatric DTG has been added to the ELMS. So we can pick which one is not true. Okay, so we're saying which of the following is not true about pediatric DTG? The bottles in the country are not child resistant and should be stored safely. The bottles do not need to be stored in a fridge. No need to report and request the pediatric DTG because it will be distributed in a push system. The pediatric DTG has been added to the ELMS. It's a very tough question, eh? Interesting. Okay, at least we've got people have been polling for the last 35 minutes, 35 seconds. We can just push it maybe to about a minute and go on. I'm sure Mr. Kabamba will do justice. So by 10:40, we'll be back on time. Okay, so we're encouraging people to poll. At least 50% of the attendance should poll. The problem with Zoom meetings is that people log in and are doing other things. But we have a good attendance of 460. Okay, thank you. We can end the poll. Majority of our participants think C was the best answer. So we'll see. I'll let Mr. Kampamba educate us.
Thank you very much, Chair. It's actually interesting. I'm looking at the polls. Sometimes it becomes very interesting when you see all the answers being picked by some people, and then of course you know that you've got some work to do. So just to, of course, the bottles in the country are not child resistant. We are going to look at that. In terms of storage, where they need to be refrigerated or not, we'll look at that. And then the importance of reporting every product, of course, should be reported on. So I hope I've given a clue. Then pediatric DTG being added to ELMIS. Thank you so much. What the product we are dealing with is a dispersible tablet, and of course has been added to ELMIS and Smart Care and various quantification tools that we'll be dealing with, and this will aid in the reporting. So please take note. Next slide. So in the first place, since we have not had this commodity, so we actually may not have actual consumption data on the ground. So this therefore means that ZAMSA would apply a push system to the various health facilities. Okay, so the initial supply of DTG at 10 milligrams to the health facilities will be through a push system. So this is where ZAMSA, of course, has a distribution list that has been determined using the numbers that we have, of course, and the treatment care for these children. And that is what they are going to use to supply to the various health facilities. And as earlier mentioned, this supply will be based on the TXCAR of the target recipients of care. This list has already been done, and I'm sure many of us know what we are supposed to receive. And then ZAMSA acting on this and would definitely push these commodities to the hubs for those that have hubs, and then last mile distribution will be done by the province itself. Next slide, please. Concerning the supply of pediatric DTG, okay, so remember we have emphasized the initial supply will be a push system where ZAMSA or the central system kicks in and takes to or makes a distribution list and takes to various facilities. Then subsequently, after, of course, we have had people use this commodity and we start getting various reports, the supply will now be through the pool system. So facilities place orders to ZAMSA using the ELMIS that we've talked about. And then these orders, like I have said, will be based on consumption data. So there is a need for facilities to capture consumption data accurately in smart care and DLMIS systems during dispensations. Without this, it is very difficult for us to know how much is needed to be given. And as it has always been, no report, no product, no program. So lastly on this slide, of course, we know that ZAMSA will be supplying based on facility report and requisition. Okay, so information is very, very key to be fed into ZAMSA. And then ZAMSA now supplies the commodities to the health facilities. So the reporting system needs to be up to speed. Next slide, please. So concerning some of the items that came in the poll question, okay, the first one, the bottles are not child resistant, and therefore, of course, we know the importance of keeping these drugs safe. Keep out of the reach and sight of children. And I know there have been some joke out there where we don't give drugs because they said keep out of reach of children or keep away from children. The issue is these drugs should safely be stored so that they are not tampered with by children. Otherwise, you may find that children open and then overdose themselves. So please, adults need to watch and keep these drugs safely so that the children cannot reach them. Storage, okay, is no need to store in the fridge, okay? So store below 30 degrees centigrade in a dry place and in original container. Of course, this has always been an issue where, of course, some caregivers or even clients prefer to put in a different package. So sometimes it's good for us health workers to engage these caregivers or recipients of care why they prefer to put in a different container than the original one. Sometimes, of course, it's to disguise. So the issue of stigma may come in and serious counseling required. But otherwise, it's always encouraged to store in the original container. We will trace certain things. Of course, the storage itself, moisture issues, expiry dates, and remember the tablets themselves do not have an expiry date on them. So we can only know the expiry date when these are in the original container, and even moisture issues, depending on where they are stored, the container is well meant for that. Next slide, please. So at this point in time, before probably the poll question, I'll ask Julia, just in case she's got something to add on. Julia, over to you. I'm sure you may want to speak to the quantities that we have at ZAMSA. I don't know. Go ahead, please.
Good morning, everyone, and thank you so much, Mr. Kampamba, for the presentation. So for me, I think I'll just say like everyone has said, we've received all the quantities we've received some DTG, 10 milligrams, a total of 33,743 bottles have been received and are currently sitting at ZAMSA with an expiry date of 2023. So we are good to go. Like everyone else has said, it all depends on us. So with regards to the facilities, facilities that are going to be, I'm sure if people have not yet received, it's not everyone. It won't start with everyone. There was a selection criteria. So like for the 0 to 4 years, facilities that were picked were those with 20 or more recipients of care. And the number of people, the number of plans on this were about 1,844. Then for the 5 to 9 years, facilities considered were those with 50 or more recipients of care. bringing the total to 3,148. So the total for the pediatrics that will be targeted in the initial phase will be 4,992 across the provinces. So a total of 19,968 bottles will be distributed to facilities. And like Mr. Kampamba said, the list will be shared together with other materials, which shows the specific provinces and facilities that will begin with in the initial phase. I think that's all I had. Thank you very much, and keep on listening.
So thank you. We'll take 30 seconds to go through our poll question. We've been seated for the last 1 hour, 30 minutes. So which of the following is not true about pediatric DTG? The bottles in the country are not child resistant and should be stored away safely. B, the bottles do not need to be stored in a fridge. C, no need to report or request a pediatric DTG because it will be distributed in a push system or with the push system. Pediatric DTG has been added to ELIMS. So we encourage everyone to poll. We'll just take a short poll, just about 30 seconds. So please quickly poll. I'm still finding this question difficult, eh? Or maybe
Yeah,
it's
interesting to see the answer. Yeah.
Okay. So I think the facilitators and experts on the panel, please do attend to the questions in the chat box so that the participant, we can reduce time and stick to time. By 12 hours we should end. So I think we've done the poll for a minute. I'll end the poll. 67, 130 participants think C is the best answer. I'll ask Mr. Kampamba maybe to address which one do you think is the best answer, since I'm not, we should have highlighted. Mr. Kampamba.
Yeah, so thank you very much. Yeah, so it's like the initial picture that we had is somehow, of course, we have had some people converted. So the best answer is C. Okay, so which of the following is not true? Remember, I emphasized that there is serious need for reporting for this DTG, pediatric DTG. And I said one slogan: no reporting, no product, no program. Okay, so let's just go through the first one. A, the bottles in the country are not child resistant and should be stored safely. That is very correct. The bottles do not need to be stored in a fridge. Very correct. D, pediatric DTG has been added to ELMIS. Correct. So the only one that is wrong, I know sometimes the is not true can be confusing in itself. So the correct answer is the one that is not true, which is C, because there is serious need to report and request pediatric DTG. Over to you, Chair. Thank you.
Thank you, Mr. Kampamba. And I think we've had a very interesting discussion. We're about to take a break. We've had 3 main presentations, where the introduction done by Dr. Ziambo, where he stated that we need to really focus on adherence and not the viral load. If our participants are pediatric recipients of care, are adherent, they're eligible to be switched to a DTG-based regimen. And remember that we use the same principles for pediatric, for DTG, for both first and second line DTG, and it can be used in TPT. For those who have TB, we need to double dose the DTG. We went on to look at counseling. In our counseling session, we noticed that we need to do a proper counseling and allow the parents to ask as many questions as possible, be open-ended and do that. And then one thing that I noted was interesting was that, yes, as the system We've given our recipients of care and guardians information. We told them we had brought them the grand news, and the grand news was good news. And in a few months' time, we're coming back to tell them we're bringing you more good news. They may be confused. So it may be confusing. Remember, we need to do that. There were concerns on Lopinava stocks that came in. Yes, we will have a few wastage because of this. Most facilities have the granules there, and we're telling them to switch to DTG. They would have a few granules wastage. I think we'll discuss in one of our scenarios on an issue of the 4 weeks, the children less than 4 weeks, and what we'll do to them. Dosing charts will be distributed to the facilities, and then we also need to look at some of those things. And Mr. Kampamba last year presented to us on supply chain. We saw the importance of us to order, the importance for us reporting. And I think not just even reporting in terms of what we've used, we would also need to do active pharmacovigilance. These are new drugs that we're bringing to this population. We need to report any adverse events that will be presented to them. So in the interest of time, I think we may need to take a few minutes break and then come back and address the next session. So I've been your chair for the morning session. We'll take, I think, a 5 minutes break, and we can get back at 10:40. So
thank you very much, Dr. Zimba, for taking us through from the first part of the orientation. I hope I'm very audible. Can someone confirm if I'm audible?
Yes, you are.
Yes, you are, Dr. Perry.
Thank you very much. So as the network has mentioned, I'm Dr. Perry Chibika from MOH. So I'll be the chair for the rest of the remaining session. So again, just to remind the network that let's observe the etiquettes. Let's make sure that we keep our mics on mute if we are not being given the floor. And of course, let's make use of the chats. I can see that it's been very active, and some of the questions that are being asked are being attended to. So try by all means to attend to as many questions as possible, but in the interest of time, I'm sure you'll bear with us. So the remaining part, I'd request that Chatonda probably you may be helping us in muting people that may forget to unmute. So the remaining part will have Q&A, and also in terms of the frequently asked questions, that will be done by Dr. Simwenda Maureen, and then we'll move on to adverse reporting, and then thereafter we'll have an interactive session where we'll go through some scenarios and role play, and then we'll also look at M&E. That will be done by Mr. Chumuka Sianyinda, and thereafter will be followed by Q&A, and hopefully should be able to close before noon. So Dr. Maureen Simwenda, are you ready?
Yes,
So,
yes. Yes, I'm ready. I'm here.
Okay, so you can take us through the.
Okay, so can I share my screen so that it's easier for me to move through the slides?
Yes, please. The host, please kindly give Dr. Simwenda permission to share.
Okay, thank you so much. Are you able to see my screen?
Yes, Dr. Simwenda, we can see it. Thank you. You may proceed.
All right, thank you so much. My name's Dr. Maureen Simwenda. I'm going to take us through the frequently asked questions. This is a very exciting and interesting session because these questions that we're going to go through are not only the questions that healthcare providers ask, but also the questions that we'll frequently encounter from the caregivers. So let us go through the questions and see how it goes. Like most of these things we have actually already discussed, but we just need to emphasize on them. So what is pediatric DTG, pDTG. Pediatric pDTG or pediatric DTG is the 10 milligrams dispersible scored tablets, which is a new generic formulation of DTG that we are going to be using in our ART program for children living with HIV who are at least 4 weeks of age and weigh at least 3 kgs and up to 20 kgs. What are the benefits of pediatric DTG? There are quite a number of benefits, and we need to really look at these benefits as we are going to be informing our caregivers on what the benefits are. So these include higher genetic barrier of resistance over the NNRTIs, minimal side effects and drug interactions, which we'll see later on, a simpler means of administration in comparison, especially to lopinavir boosted with ritonavir, and improved adherence, as well as a more rapid achievement of viral load suppression, which I think was earlier mentioned. So when is pediatric DTG expected to be available? So currently, we already have the pediatric DTG in Zambia available, and the 2 generic manufacturers, that is the Viatris, formerly known as Mylan, and Macleods, have filed for regulatory approval of pDTG with the US FDA. So both the Viatris and Macleods have received tentative approval. But for Viatris, the 5 milligrams actually recently, the 5 milligrams but not 10 milligrams recently was approved by the US FDA. But what we should really know ultimately is that we currently have the pediatric DTG 10 milligrams available in Zambia. So how does pediatric DTG compare to lopinavir in terms of efficacy? So we look at the studies that have been done, but currently there is no published head-to-head trials that have compared DTG to lopinavir boosted with ritonavir in children. However, in adults, there have been 2 studies that have demonstrated some superiority of DTG over lopinavir boosted with ritonavir. Of note is the Downing study where it was demonstrated a higher rate of adverse events in lopinavir in adults as compared to DTG. For the treatment naive studies of DTG, particularly for the Flamingo studies, it demonstrated a significant improved viral load suppression in favor of DTG. So we really need to maybe even just go back and look at these studies so that as we start and roll out pediatric DTG, we have this information and we can even utilize it as we inform our caregivers and counsel them. So in terms of tolerability, how does pediatric DTG compare to lopinavir boosted with ritonavir? So pediatric DTG has better side effect profile as compared to lopinavir boosted with ritonavir. It's also has shown improved tolerability, especially when you look at the side effects that are associated with lopinavir, which include diarrhea, hyperlipidemia, and decreased bone density. Again, the studies that were done, particularly in adults, which is the Downing study, which was focused on adults on second line therapy, and found out that at least a 4% rate for grade 2 to 4 adverse events for DTG, as compared to 14% rate of grade 2 to 4 adverse events for lopinavir to boosted with ritonavir. So mainly in clinical trials, there's a grading system for adverse events ranging from 0 to 5, but mainly we're looking here at those adverse events that fall under the grade 2 to 4. And of note, which is diarrhea and nausea. When you compare DTG to lopinavir boosted with ritonavir, the rate of diarrhea was 9% in DTG in lopinavir boosted with ritonavir, compared to the 3% that was observed in DTG. And when it came to nausea rates, there was 34% observed in those on lopinavir boosted with ritonavir, compared to the 10% in those ones that were on DTG. For the single study, which focused on adults, clients that were started on first-line therapy with DTG, it was noted that there were fewer clients that were on DTG that discontinued due to adverse events. Of note, 2% that were on DTG discontinued, as compared to 10% that discontinued that were on efavirenz. So for the neuropsychiatric symptoms, that includes dizziness and sleep disturbances, occurred at lower or similar rates in the adult patients receiving DTG, or primarily when you compare it with efavirenz. But for insomnia, which is the commonly reported neuropsychiatric symptom for DTG, in the single study, it demonstrated that 17% of the adults reported insomnia versus 12% on those ones that were on efavirenz. So how does DTG compare to lopinavir boosted with ritonavir in terms of convenience? And that's one of the things I guess our providers will actually need to be informed on, and one of the factors that things that we really need to look at when counseling them. So pediatric DTG is taken only once a day, whereas the LPVR is taken twice a day. Already that's a plus for the caregivers, to convince the caregivers and even some of our clients who we are able to talk to. And the dispersible pediatric DTG tablets, it eases ingestion versus the lopinavir boosted with ritonavir tablet, and it's easier to administer than the pellets and also the granule formulations as we have already observed. Then the pediatric DTG dispersible tablet has some flavor, strawberry cream, when dispersed in water, and strawberry always smells better, and so it's also more palatable in comparison to lopinavir boosted with ritonavir, which has a bitter taste, and this definitely will have an effect on adherence. On the pediatric DTG, it's also far much less bulky when you compare it to LPVR granules. There's no need for the caregivers to carry plastic bags. At one of the facilities, really had a challenge on how to package those boxes of the granules. So we now have the pediatric DTG that is actually less bulky. So we don't need to ask our caregivers to come with their plastic bags, because to be easier for them to carry the pediatric DTG tablets. So how should the pediatric DTG be administered? As earlier mentioned, we need to add the pediatric DTG to 5 ml, that is 1 teaspoon, if at all we are using the half tablet or the 1.5 tablets, or 10 ml, or which is 2 teaspoons if we are using 2 or 2.5 tablets. So this should be added to clean water, and then should be stirred gently until the tablet disintegrates, and then should be then administered to the child. If the tablet is not dissolving or it's forming lumps, then we need to slowly add some additional water until the tablet completely dissolves. And then if there's any medicine that remains in the cup after administering the solution to the child, the caregivers should add an additional 5 ml, that is 1 teaspoon, to the water, and then swirl gently and give it to the child. So what we really need to emphasize is that all the solution has to be taken, at least all the dissolved tablet has to be taken. And we should also emphasize that the children or the caregivers should ensure that the mixture is given straight away or within 30 minutes of mixing the tablets into the water. Please, let's emphasize on this. So can the ABC 3TC 120 60 milligrams dispersible tablet or other dispersible backbones and DTG be dispersed and administered simultaneously in the same solution? The good thing is that we can actually mix and administer simultaneously. So the DTG can be administered in the same solution of clean water with the other dispersible tablets, that is the abacavir and lamivudine 120 60 milligrams. Then we also need to make sure that we are following the weight bands on the dosing charts for both the pediatric DTG and also the abacavir and lamivudine combination. So when co-administered, we need to make sure that we increase the amount of the clean water to 10 to 20 ml, that is 2 to 4 teaspoons. And when administering, we actually follow the same instructions or steps that I previously mentioned in the previous slide. And then in all dosing scenarios, it is very important to make sure that all tablets are properly dissolved and are completely taken by the clients. Okay. Be dispersed and administered in liquids other than water, such as juice or breast milk, or in food such as yogurt or porridge. So another good thing is that pediatric DTG, ideally, we want it to be dispersed in clean water. However, there are children who cannot take pediatric DTG with water, and so it can be dispersed in liquids or other foods other than water. So we just ensure that when the pediatric DTG is dispersed in other liquids or foods other than water, we need to make sure that the children consumes all the liquid or food used for mixing. So if it's a porridge, you need to make sure that the porridge or the yogurt is completely consumed by the child. So we need to ensure that to emphasize to the caregivers that once they're preparing these liquids or foods, they need to make sure that they know that the child will complete that quantity that is being prepared. Then over how many minutes should a caregiver be advised to have their child swallow the pediatric DTG solution if it cannot be swallowed at once? I think we have heard, and we better emphasize that the caregivers should be advised that children should either drink the water-based solution or other liquids or food, preferably straight away or within 30 minutes. This again should be emphasized to the caregivers. Then should children who are stable on other regimens be transitioned to pediatric DTG? I'm sure we have all, particularly providers at facility level, we have all encountered this question when we were transitioning the PEDS clients from nevirapine-based regimen, and also recently from the efavirenz-based regimen. So why should a child who is stable on lopinavir-based regimen be transitioned to DTG? So the WHO guidelines are clear and have provided guidance on proactively transitioning children above 20 kgs on other ART regimens, that is DTG based. And also currently the Ministry of Health recommends that all existing children who are 4 weeks of age and weigh at least 3 kgs and up to 20 kgs should be transitioned to the pediatric DTG in a phased out manner, in a phased approach. We may encounter a few challenges here, especially because recently we were transitioning children from, particularly those we transitioned from efavirenz-based to lopinavir based, because DTG has just come in, especially in this age group, and also the children that are falling in this weight band. So we need to sit down with the caregivers and explain to them. We have the information, we have looked at the data, the available, evidence. So we need to utilize that information we have, simplify it, and make sure that our caregivers understand. We don't want them to be confused because in the end, they can actually be confused, especially because of the recent transitioning of clients from efavirenz to lopinavir based, for those ones that we recently transitioned. Then when we look at switching based on a viral load test, is a viral load test required before switching a patient to pediatric DTG? I think this was really nicely explained by Dr. Kozia. So we really need to assess adherence. For the stable children with prior history of suppressed viral load and a good adherence history, demonstrated good adherence, having a latest VL result before switching should not be a requirement. It should not delay the process of transitioning. We know that it is recommended, but it should not delay, because you have the client right in front of you. You understand the client. We understand the clients. So for those ones that we know are stable, for those ones that we know that have demonstrated good adherence, and they have prior history of suppression, let us transition them and not delay the process. So access to viral load testing should not be a barrier or major source of delay for a child to be switched to the pediatric DTG. We know that it is preferred to have a VL result for overall health management and also monitoring of the child before switching, if it is possible to do so. So what are the interactions between DTG and commonly prescribed medications? So there are drugs that are known to be metabolic inducers like phenytoin and phenobarbital or phenobarbital. So co-administration with particularly these anticonvulsants is not recommended with DTG. Please let us all consult. We have expert consultation at provincial level, even at district level, or we can even call the 7040 line where we can also consult. Rifampicin is well known to lower DTG levels, and co-administration is not recommended at standard doses. So the clinical studies have shown and also support double dosing of DTG for children that are being treated for TB with rifampicin containing regimens. Please, we are not saying that it's not recommended. It is not recommended at standard dosing. We have to double the dose if at all the TB treatment contains rifampicin. For the iron, aluminum, magnesium, and calcium containing medicines, which bind with and reduce absorption of DTG, if at all we are co-administering these medicines with DTG, we should make sure that the medicine is taken with food to enhance the absorption of DTG. Or, if possible, at that time when these medicines are required, we should make sure that maybe there's some adjustment or they are taken at alternate times, maybe 6 hours apart. So as we add on these drugs, particularly these drugs are very common in the OPD. So not really in ART, but they're also being used in OPD. So let's make sure that we take note of this and ensure that the medicines are taken with food or are taken at least at alternative times, preferably 6 hours apart. Then how does dosing differ between the DTG dispersible and the fume-coated tablets? So it is again well known that the dispersible tablets have greater bioavailability as compared to the fume-coated tablets. So the DTG 50 milligrams that we have is actually fume-coated. So the 50 milligrams DTG that we use in the older children and in the adults is equal to the 30 milligrams of dispersible of the dispersible tablet. That is 3 times 10 milligrams of the pediatric dispersible tablets or dispersible tablets. So in the event that there's need to transition between the 2 formulations, we ensure that the appropriate DTG dosing is used. Particularly, this will be encountered in the older children. Viv Healthcare, which is the originator of the 10 milligrams fume-coated tablets of DTG, and the currently 10 milligrams dispersible tablet, they are not interchangeable. So I think we should just know about this as well. So how is the dosing of pediatric DTG determined? So drug absorption and metabolism in children is affected by many factors, and to note is, the growth, which is rapid in children, especially in the younger children, and also maturation as reflected by weight, body surface area, and also age. So there's need to accurately determine the safe and effective dose of a drug for any individual, depending on our understanding on the pharmacokinetics of the drugs. That is exactly what the body does to the drug once administered. So there are quite a number of studies, even in the clinical trials. They look at pharmacokinetics, and the dosing is based on these pharmacokinetic studies. So they're usually conducted in adults first. I think we all know that mostly the clinical trials include adults first, and then studies in children coming later, mainly aiming at finding out the right dose in children of different ages and weights in order to achieve the same levels as in adults. So in children, there are two randomized multi-country pharmacokinetic studies that were done. And this is the Odyssey and also the Impact P1093 studies. And these are the studies that have provided the necessary safety data and the dosing of the pediatric DTG in children. And we'll definitely have the dosing chart. And it was earlier, we earlier looked at it in one of the slides that Dr. Kozia presented. So a lot of studies are done for the children. At least we know that the Odyssey and Impact studies are providing the evidence that we require for dosing based on the pharmacokinetics studies. So why does pediatric DTG dosing jump from 0.5, that is half a tablet, to 1.5 tablets between 3 to 6 kgs and 6 to 10 kgs weight bands? Again, there are a lot of changes that happen in young children, particularly on drug metabolism. The pharmacokinetic studies of pediatric DTG in children have shown a lot of variability in drug levels for children in the 6 months to 2 years of age, and also 2 to 6 years of age, with some children having levels that were lower than the target levels as determined in the adult studies. So for this reason, because of what was observed or what is still being observed, a higher dose in these age groups was studied closely and found to reliably achieve the target drug levels for all the children studied. So those ages roughly correspond to the weight bands of 6 to 10 kgs, 10 to 14 kgs, and 14 to 20 kgs. Pretty much the same what happens in the other clinical trials for the other drugs that we're already administering, and also looking at how we are using the different, dosing in the different, weight bands, particularly for children. So it's also important to understand that pharmacokinetic studies really determine the dosing, and that's why there is that jump from half a tablet to 1.5 tablet between those two weight bands. So this, I think, is the last slide. Can I administer DTG with TPT drugs? This was earlier asked, and I think it was ably addressed. When we look at the current regimens that we have, or the current drugs that we have for TPT, which is the INH, and also the 3HP. These have actually demonstrated that studies have demonstrated and support co-administration of DTG with INH and 3HP. The one that is of concern is the rifampicin, which we are not currently using for TPT. So 3HP, again, just to emphasize, does not contain rifampicin. but has rifampicin. So the impact study again demonstrated that we can safely co-administer DTG with INH containing TPT regimens, which is the 3HP and the standalone INH. So the Ministry of Health currently recommends the use of INH for tuberculosis preventive therapy, TPT, for children living with HIV less than 20 kgs. So we can safely and confidently co-administer DTG with INH containing TPT regimens. So this is the last slide. I'm not sure whether we're going to take questions, but I know that there could be some questions in the chat. I hand over to Dr. Piri. Thank you so much.
Thank you very much, Dr. Simwenda. I must commend you. I think it was very clear and precise. So if the network has got some questions, we can still hold on to them, but we can take advantage of the chat. And I've noticed that already the team is doing great in terms of responding to some of the questions. So we heard from Dr. Simwenda. Maureen, she took us through and reminded some of the key issues that were already discussed in terms of how we can administer the pediatric DTG 10 milligrams, what to follow. And also she has actually told us that this drug is actually available. And also she also explained that in terms of some questions that the people may ask, why switching from DTG and not maintaining the children on lopinavir. So in terms of the studies, we don't have studies that have been done on children looking at the superiority between the two. However, she mentioned that in adults, there are 2 studies that were done. The Donning study that was looking at the second line use of lopinavir, ritonavir, and DTG, and also the first line, the single study. So the 2 showed that actually DTG was doing better than lopinavir, ritonavir boosted because of some other aspects in addition to viral suppression, such as the well tolerability because of little side effects. Of course, it was mentioned that insomnia was slightly higher in the use of DTG as compared to lopinavir in the single study. And also, we are reminded also that in terms of comparing the DTG pediatric to the granules that we have been using, as Mpumbi mentioned that we were excited initially, but now we've seen some challenges. So she took us through and shared some of the advantages that which it's exciting because to be a once a day dosing drug, easy to administer, and it's got a nice taste. So it's more palatable. We're told it's strawberry taste. And also in terms of the quantities, I think we saw for the facilities that had started using granules, we saw that the majority of the caregivers could come with the big bags actually to carry a number of sachets, but now to be less bulk in terms of the tablets. And also she reminded us in terms of the interactions, drug-to-drug interactions. I think this was also area mentioned. We need to pay particular attention in any or at all times when you are prescribing drugs to identify if there's any interaction with other drugs, in particularly, I think in the use of antiepileptic drugs. And also she also mentioned from this last slide in terms of the use of TPT, the fears. So we are safe to use DTG with those that are on TPT because the drug of choice that we are using so far doesn't seem to have a significant interaction with the DTG, except for those that are on TB treatment. We need to be cautious because we have been reminded that we need to double the dose of DTG for those that have HIV, TB co-infected and on ATT. So we move on to the next part of the presentation, where we'll look at the adverse reporting, and this will be taken by Msanide. Msanide, are you ready? Msanide Sakala. Mr. Sakala, are you ready? Okay, I need a confirmation. Okay, Dr. Ziambo, it appears Mr. Msanide is not there. Mukumbi, are you able to take us through this? Okay, so we've just been reminded that it appears Zamra is unable to unmute. So Chatonda, please help. Let's help Msanide to unmute. Thank you.
It's Miss Siame who's supposed to give this session.
Okay, so thank you for that clarification. I was looking at the schedule. So Ms. Siame, please go ahead.
Hello.
Hello. Good morning. Okay. We can hear you now.
Okay. Good morning. This is Mwewa from Zambia, Mwewa Siane. I'm the Senior Surveillance Officer for Pharmacovigilance. So I'm the one that is taking you through this presentation.
Thank you. You may proceed, Madam.
Okay, so we are going to look at the common side effects and reporting of adverse drug reactions. Next slide, please. So by the end of the session, we'll be able to list the common side effects of pDTG, manage the common side effects of pDTG, then differentiate between an adverse drug reaction and a side effect, and state why, what, when, how, and where to report adverse drug reactions. Next slide, please. From the current DTG that has been introduced in the adult population, these are the common side effects that we've been seeing. These are headache, insomnia, and fatigue. So those are the common side effects. And then during the clinical trials, there were no participants that were permanently discontinued from DTG due to adverse events from pDTG. Other possible side effects are weight gain, which has been a common side effect for the adult DTG. Although there's no current evidence to suggest that there's a problem with weight gain in children, however, this needs to be monitored regularly. The incidence of high blood sugar as well following DTG has been reported in the ART experienced adults. And then this includes the related symptoms of polyuria, polydipsia, and these should be routinely sought. The management of the common side effects. So side effects mostly occur on the first taking of DTG, and they improve within 2 to 3 months. So these include things like headache and fatigue. So it's important to take history, provide painkillers as appropriate, then advise the caregiver to ensure that they adequately hydrate the child and they get enough rest. For insomnia, the advice would be for the caregiver to administer the medicines in the morning rather than in the night. So I want to just differentiate, because there's usually confusion between adverse drug reaction and the side effect. So an adverse drug reaction is a nauseous and unintended response to a medicine, which will occur at doses that are given at normal doses given for prophylaxis, diagnosis, or therapy of a disease, or modification of a physiological function. So it's nauseous in that it's unwanted, it's unpleasant. That's what that means. Then for a side effect, it's also an unintended effect of a pharmaceutical product occurring at normal doses in humans. But for this one, it's related to the pharmacological properties of the drug. So that is the difference between an adverse drug reaction and a side effect. Why should you report adverse drug reactions? So as has been indicated, clinical trials have been done. However, clinical trials have limitations in that patients used in clinical trials are of a limited number. The clinical trial conditions also differ from clinical settings. There's a limited geographical area within which these clinical trials are done. And the duration of clinical trials is also limited. It usually just lasts a few years. So for us, pDTG is a new drug on our Zambian market. So it may not be new in other parts of the world, but for us in Zambia, it's a new drug. So that's why it's important that we should monitor this drug and report any adverse drug reactions. And it's being used for the first time in our pediatric population. So it's important that we closely observe and see how our pediatric population is going to respond. It may not be exactly the same as has been in the adult population. So currently there is no safety information within our local setting on this product. So there's need for us to detect, record, and report all adverse drug reactions to be able to develop our own local database and inform decision makers. Next slide, please. So what should be reported? So we need to report all suspected reactions, including minor ones in the case of new medicines. So as already said, pDTG is considered a new medicine on our market because we're using it for the first time. So we need to report all suspected reactions, including minor ones, what would consider to be minor ones, so that we're able to develop a profile of this product in terms of safety. Then all serious reactions as well should be reported. Then we should also report any increased frequency of a given reaction if this is observed. So that is very important as well. Then we need to report suspected interaction. We know that this product will be taken alongside other products. So if we suspect any interaction, that should also be reported. Next slide, please. So when should you report? So any suspected adverse drug reaction should be reported as soon as possible. And even if we're not certain that the drug or the medicine caused the suspected adverse drug reaction, or we do not have all the details, we can still report. Next slide. Then how are we going to report? So you can report using the hard copy ADR reporting forms that are available at health facilities. These hard copies can either be submitted physically or emailed. Then we can also use our mobile application, Med Safety app, that is available on Google Play Store. then reports can also be sent through the electronic reporting form that is available on the ZAMRA website. That is www.zamra.co.za. Slide, please. So where should these reports be sent? So all completed reports should be submitted to the National Pharmacovigilance Unit that is based at ZAMRA. And that is the email address to which the reports can be submitted. That is the line that can be used in case of any queries. And we also have a WhatsApp line, and this can also be used to send pictures of the reporting form. So what are the key points? It's important to manage adverse effects symptomatically. And then most of the side effects that have been observed, that is in the adults, are self-limiting and may not warrant premature discontinuation of the drug. However, if they persist for more than 2 weeks, might consider changing the medication. So it's also important that to ensure that the healthcare workers are proactive in supporting the pharmacovigilance system with regards to the pDTG, given that it's a new formulation on our Zambian market. I believe this is the last slide. Thank you.
Thank you, Ms. Siame. Thank you very much. The team network will agree with me that that was a very important component and very informative. So we'll straight away move on to the next part of the presentation. So we can keep on pushing questions in the chats, and the respective presenters may be able to respond so that we save on time. So we'll move on to the next part, which is the scenarios and role play. That will be led by Dr. Wangera Muviana. Dr. Muviana.
Thanks very much, Dr. Piri. So for the next section, we'll ask that people actively and freely participate by raising their hands, and then I'll call them out. So we can go to the next slide. So I'll be reading through the scenarios, and then we ask for a show of hands for people to react to the scenarios and contribute. In scenario 1, we have a newborn HIV-exposed baby, 1 day old, weighing 3.5 kgs, who has just had a positive HIV nucleic acid test at Mazabuka General Hospital. What will be your immediate actions and follow-on actions at 2 weeks of age and 4 weeks of age? So can we have show of hands?
Atasha has raised her hand.
I don't know, I'm not able to see the hands. You can go ahead.
Tashi raised her hand.
Okay.
Please go ahead. I think you need to help with unmuting.
Hello. Yeah, since we are learning, I stand to be corrected. So this child we are saying is 1 day old and has tested positive. So we are going to put this child on AZT3TC NVP, and we are going to do a follow-up NAT test to confirm. And then at 2 weeks, we are going to put this child on ABC3TC Lopineva until the child reaches 4 weeks, where we are going to switch this child to ABC3TC DTG. Thank you.
Thanks very much, Tashi. Any other views? Is there any hand that has been raised?
No, I can't see any, but you can still, through your authority given by the chair, you can ask anyone on the list, on the chat.
Can we have Agnes Songiso? Sorry, I'm just looking at alphabetical order. Maybe you can help with unmuting.
Yeah, so Chatonda has indicated, okay.
Helping unmute?
Yes.
I'm helping, but then I've just asked them, it's up to them to unmute themselves.
Okay, thank you.
Oh, okay. So people are free to unmute themselves.
Okay, so Dr. Muyana, on each role play, how many participants are you allowing for before?
Can we have at least 2?
Okay,
Can we have at least 2 contributions?
Okay, fair enough. So
there was Constance who raised her hand.
Let me check. Okay, so if there's anyone who raised their hands, you can go ahead and unmute yourself. Okay, there's a hand. Yeah, please go ahead from Mwaba Mlenga. I know. No, it's Bismarck.
Bismarck.
Shamuzumba.
Thank you so much, Doc, for my contribution on the first scenario. This is the child who has already tested for NAT, and NAT is actually the most sensitive test that it tells us whether the child is HIV positive or not. So for me, on this one, the immediate action I'll take is to initiate the child on ABC3TC and Lopineva. And I would also do another NAT to confirm the first NAT result, whether it's a true positive or a false negative. I submit.
Thanks for those 2 submissions. What about treatment?
So, hello? So the child will still remain on ABC3TC Lopineva, but that one will be based on the weight of the child. So since this child is weighing 3.5 kg, we'll give the ABC3TC Lopineva based on the weight of the child. Thank you.
Through the chair, can I say something?
Okay, so there's another submission.
Please, Richard. That will be the last contribution.
Okay.
Yes, that will be the last one for this case. Please go ahead, Richard.
Okay, I'm looking at, of course, other presenters, our speakers have spoken concerning the issue, but I'm looking at us just from talking about the DTG, which can be used in this way. But of course, this child has been is exposed, and the NAT has become HIV positive, So now, instead of using LPVR, I think in this case we'll resort to use DTG, since the weight band and also the weight falls also still in the same DTG regimen. So we can, in the part of treatment, of course, there's a part of prophylaxis part. In the part of treatment, use ABC3TC then plus DTG 10 milligrams. My submission. Thank you.
Thanks for the 3 submissions. So I'll quickly summarize. So for this infant who's 1 day old and weighing 3.5 kg, I think we'll all agree that we need to repeat the NAT, so that's good. And of course, we shouldn't forget the counseling. A mother has just been told the baby is HIV positive, so we need to counsel them on the condition, the treatment going forward and adherence. So although the baby is 3.5 kgs, remember DTG we're using from 4 weeks, we are not just looking at the weight. So we will not immediately start DTG. So previously we've been using lopinavir from the age of 2 weeks, but in this case, I think we have discussed that lopinavir will not be used. We will start the baby as before on AZT3TC nevirapine. In the previous guidance, we would be changing treatment 2 weeks later when the baby is 2 weeks to lopinavir based. But for this new guidance, we will not change. We will continue the same treatment until the baby reaches 4 weeks. That's when we'll be able to use our DTG based regimen, ABC3TC and DTG. So if we're going to change, we'd actually be changing just for 2. We shouldn't forget that now we have OVC services available. So we should try and link all our HIV positive children to OVC services. We can proceed to the next scenario. Can we proceed to, oh yeah. For scenario 2, we have a 7-year-old child, Melanie, weighing 22 kgs, who has been attending Twapia Clinic and is on ABC3TC lopinavir tablets. He had 3 viral loads done, which is 500,000, then 600,000 and 900,000, with the last 2 done before and after well-structured enhanced adherence counseling sessions, where adherence was assessed with a community-based volunteer and supervised, directly observed therapy was implemented. What will be your next course of action? Show of hands and then unmute yourself, please. Any hands?
So far, I can't see any. Okay, there are 2 hands. There are 2 hands. 3
Yes,
actually
they
now.
are. Who are they?
Yeah.
The first one can unmute themselves and proceed.
So there's Tashi Lungu, and then there's Iso Chilala and David Muituma, in that order.
Thank you.
Okay, thank you. Looking at this scenario, I'll have to look at the possible causes of the unsuppression. And looking at the well-structured EAC that has been done, we'll have to know probably is it treatment failure or is it still the issue of adherence? Because here we are looking at ABC3TC lopinavir, and basically on standard, these are drugs that are taken twice in a day. Okay. So I think I had even asked this question earlier to Dr. Ziambo, where I was saying, how do we look at these children who probably, it may not be treatment failure per se, but it's looking at the issue of the frequency and them forgetting to take and the like. So I'm going to analyze as a clinician and see what really is causing this unsuppression. If it's something that can be corrected with changing the treatment regimen there, I will not rush to taking this child to second line. I would change this child now to a DTG-based regimen where I would want to see them taking their drugs at least once in a day and observe them. If it is really a treatment failure there, then I'm going to switch them to a second line, which will have a DTG kind of component in it. I stand to be corrected. Thank you.
Please mute Shadrach. Thank you. Thanks for the contribution, Tashi. Can we have the next person? Forgotten the name.
So Chilala, and the actual 6 now, the 5.
We'll just have the 3, I think.
Okay, good morning. Iso Chilala here. I'm a pharmacist. I think looking at the scenario, the issue of adherence has been addressed. And I think for me, I'll take it, this child has failed on treatment. So the next step I'll take would be put the child on AZT VTC with DTG. Thanks, I submit.
Thank you, ISO.
And then we have David.
Can we have the last submission?
David Mwitumwa.
Hello, good morning. I think looking at the scenario, we have seemed to say like the IAC was well done and was well structured, but the VIA was too high. And then looking at the treatment which the child was on, so we'll definitely go to the second line treatment, which is AZT3TC and DTG. I submit.
Thank you very much for the 3 submissions. So in this child who's had 3 high viral loads and seem to be getting higher, and we've been informed that adherence has been managed very well, we should really be thinking the child is failing treatment and going on to the second line treatment. In a child this age, apart from changing treatment to second line, we also need to start thinking of initiating disclosure, depending on the maturity of the child. But as we manage the child, also think of the whole family. Are all the other siblings tested? And as mentioned in the other case and all other HIV infected children, we should be considering linking. I don't know if there are any other additions. If we can do genotyping and it's available, please go ahead and do it for failing treatment according to the new guidelines. We go to the third scenario. A 23-month-old HIV-exposed baby has just had a positive determined test. Does this child need follow-on testing? And if this child is HIV positive, what ART regimen will you place this child on? Again, show of hands, then we'll have contributions. Are those new hands? David, is that a new hand?
These were odd hands. I'm not sure. There's Constance.
But Constance
Karumbano.
So we can start
the
with
new hand is
Constance, then Charles.
And then Charles.
Constance, you can go ahead, then Charles.
Hello? Hello?
Please go ahead.
Hello? Can you hear me?
Yes,
Hello?
please go ahead.
Yes, this is Constance, the clinical officer from Kazimba.
Please go ahead.
Yes. According to this scenario, this child is already over 23 months old and is ARV positive. And if you convert it to years, this child is about 1 year, 11 months old. So the determine, you can just confirm with the SD bioline to confirm the HIV results. Then the regimen, this child can be put on ABC, 3TC and DTG, pediatrics. Yeah, and we also have to consider
So
when.
you said
Hello?
You said ABC, 3TC, and DTG?
Yes, pediatrics.
Okay, thanks.
Okay.
You can carry on.
And we also have to consider when this child is stopped breastfeeding. Maybe we can also ask the mother when the child stopped breastfeeding, so that we rule out the antibodies of the mother. Yeah. And if this child is still breastfeeding, maybe we can also go for for the DBS PCR. Thank you.
Thank you very much, Constance. We'll have Charles. I've got a few more hands, maybe Charles, then Nelly, and then we'll wind up the case. Mongo, you can answer the next case. So Charles, please.
Then the adverse effect, the client's advised to report any.
Charles, is that Charles? You can go ahead. Charles first, then Nelly. Okay, if Charles is not available, Nelly, you can go ahead and mute yourself. Please go ahead.
Constance, just unmute yourself.
Hello, this is Nelly. Hello, you are able to get me?
Yes, we can get you. Just requesting that Constance, kindly unmute yourself. Kindly mute yourself, sorry. And Nelly, go ahead.
Okay, this is Nelly from Kamala Clinic HNP. Yes, I think we need a follow-up test, and we can follow up with NAT. Then the child can be initiated on ABC3TC, Lopinava, or ABC3TC, DTG if available.
Thank you very much, Nelly. Maybe we can have the last contribution from Mongo Lioyelo, since the hand was up and Charles is not around. So Mongo, please go ahead, then we can finish off the case. Who's representing Mongo?
Okay.
Have they been disconnected?
Okay, maybe I can represent Mango. Hello.
Please go ahead.
I was saying.
Please go ahead.
Yes. I was saying this child, we need to do a PCR to confirm the positive status, and then commence the child on a DGT-based regimen. And at the same time, we need also to find out from the mother the contributing factors as to why this child tested positive at almost 24 months, at 23 months, after we fared very well all along. And yeah, and then refer the child to the OVC. Thank you.
A 23-month-old child, according to our guidelines, anyone below 24 months, we still need to be doing that. We do not confirm HIV status just with a rapid test. So yes, we go ahead and do a NAT to confirm HIV status. And in terms of ART regimen, I think we have, please mute my Mbolo.
That's hold on, Dr. Muyana. Katonda, kindly, Dr. Zimba, kindly help us to mute people that are not on the floor. Thank you. You may proceed.
And I think, thank you. So I think the contribution about finding out what may have gone wrong, asking the mother about her adherence to her own treatment is very important, as the mother may not indeed have been taking her medicine well. And if she has other children, that may also affect the other children. And if the child is not infected, because we haven't yet confirmed, we still need to reinforce adherence in the mother. So it's very important to be holistic in our approach and not just focus on the HIV test and treating the child. As usual, yes, we talk about linking to OVCs and looking for HIV in any other siblings if they are not yet, if they are there and they are not yet tested. So yes, for the drugs, according to what we have been learning, the choice would be ABC3TC DTG, unless we don't yet have DTG in our facility. So thanks for that scenario. We can go to the next one. We can go to the next slide. Thank you. So scenario 4, she comes for a clinical follow-up and her last viral load, done 6 months ago, was 700 copies per mil. Describe how you will transition her to a DTG-based regimen. So do we have any hands? We have 2 hands. What's that? Please go ahead and unmute yourself. I'm not able to see whose hand it is. That's no.
So we have hands from Laston and Constance.
Laston. So Laston, you can start, and then Constance. Unmute yourself and contribute. Thank you.
Good morning.
Please go ahead.
Okay, this is Laston Mudikula from Mongo, Lewanika General Hospital, to be specific. Yeah, looking at this scenario of a 2-year-old baby weighing 14 kg who's attending a clinic at Kabondi, been on ABC 3T and Lopinavir. Yeah, so in line with transition into DTG, if I remember very well in the presentation, I think we were reminded to say really viral load should not be something to make you not to transition your child to DTG. Of course, we've seen the last viral load was less than 1,000 copies, which tells us that the child was suppressed in the last viral load, and it's still a valid viral load at the time we are seeing this child. So I think the best things to do actually would want to first not to forget talking to the caregiver. If it's the mother or whoever brings the child or is staying with the child, could be the guardian, the grandmother. We need to make sure that we make them understand why it is very key for us to transition the child to DTG. Then we also need to follow the steps to explain to them on how they should be given this DTG, which is a new drug, and also explain what they may anticipate in terms of side effects, if there will be any, and wanted to find out if the child is on any drugs which may counteract with the DTG. Could be the child, maybe the child is on antiepileptics like phenytoin. We want also to find out so that if that is a contraindication to DTG transition, you do not put the child on DTG. Then you also want to find out if the child is not on TB drugs, so that if they are on TB drugs, you would want to double the dose of DTG. That's my submission. Thank you.
Thank you very much, Laston. We can have Constance and then Sangwani.
So during this
Constance,
campaign,
please go ahead.
We are looking at quite a number of issues. We're looking at the viral loads. We're looking.
Constance, please unmute yourself. Is Constance there? Maybe it's an old hand. Sangwani, you can go ahead.
Okay, I'm from Mansa General Hospital under ART. My name is
Mansa.
Dr. Gondwe Sangwani. Yes, so what I would do for this particular client is first to explain to the caregiver on how to administer the drug, the way we explained, to mix it with water, yogurt, and make sure it's given within 30 minutes. And then also explain to the caregiver what side effects to expect whilst the child is on this medication. Then also explain if the child is found to have TB, you can also explain how we give the drugs. And then also encourage the caregiver to bring the child to the hospital frequently whenever the child is ill, so that we can be able to assess for side effects. That's what I would do for this particular child.
Please mute Amake Douglas. Thank you. Thank you for those 2 contributions. Very important contributions. So this is a child who is suppressed on the current regimen. So as mentioned, it's very, very important to to counsel and explain why you're going to change treatment which seems to be working, and because you are changing what to expect if there are any possible side effects, obviously the child and the parents would want to know what may happen if they are changing to a new drug. So all that counseling you do when you're starting the drug for the first time should indeed take place. And then you go ahead and explain how the medicine is going to be given, and linking to OVCs as usual, and testing the other siblings if they are not tested. For scenarios.
Dr. Muyana, how many scenarios are we remaining with? Dr. Mangera.
Scenarios 5. I think 6 scenarios.
Okay, because in the interest of time, we had planned to end this by lunchtime, so by noon.
Okay.
Yeah, so I suggest.
So we'll quickly go through this one.
Yes, let's quickly go through this one.
Yeah. So a 5-year-old child, Malumbo, weighing 17 kg, has been attending Twapia Clinic and has been on ABC3TC lopinavir tablets for 3 years. His last viral load was a year ago and was under 50 copies. He and his parents have religiously kept clinic appointments and satisfy adherence assessment. What will be your next course of action? I think this is very similar to the previous one, so we can probably proceed to the next scenario. Can we proceed? A 3-year-old child weighing 10 kg has been attending Solwezi General Clinic and has been on ABC3TC lopinavir for 24 months. His last viral load was a year ago, 2,000 copies. He has had his EAC sessions but doesn't keep appointments. How will you transition this child to pDTG? So maybe we can just have one contribution and then we wind up.
Yes.
I don't know if there's any hand. One contribution.
So far, I haven't seen any hand.
Anybody?
So there's Mangara Andrew. Can you go ahead? Mangara Andrew, can you mute yourself and make your submission?
Raise a hand.
Good morning. I think for this scenario, what I would do is try to, since we've already been shown through the EAC sessions to say this child is not keeping appointments, try to engage further with caregivers on how best we can improve the situation with keeping appointments. And then I think given the unsuppressed VL, you keep the child on the current regimen and repeat a VL after EAC session is EAC sessions are satisfactory. That is to say, you are now sure that adherence is being followed up as agreed. The child is not missing doses and is not being underdosed or overdosed by the caregiver. My submission. Thank you.
Thank you for the submission. So indeed, in a case like this, we don't want to rush to switching, but we would like to make sure the adherence issues are sorted out. It looks like they're coming for their sessions, but they still have a problem. So you may want to link them to any support services, community-based volunteer to follow them up, probably help with directly observed therapy. And if you have support for OVC services, you go ahead and link them. We can proceed. We can proceed. I think this is the end of the
Dr. Muyana, we lost you.
Session. Yes. Hello, you can hear me?
Yes, we can hear you, but we had lost you at some point. Thank you very much.
I was just saying it's the end of the session. It was supposed to be very practical, but we've done it virtually and we've had good participation. So thanks very much for the participation from everyone.
Yes, I agree with you. I think the network has been very active and we commend them for that. We know we've kept you seated for more than an hour now, but we are almost concluding. We have one more session 7, the M&E. So Chimuka and the team, are you ready? And after this, then we'll allow some few questions that probably were not addressed in the chat. So we encourage the team to continue sending questions or clarifications or anything that needs to be clarified in the chat. So far, we are doing very well. Thank you. Chimuka.
Good morning. This morning or afternoon, Doc?
Afternoon, Chimuka.
Okay. I can go on, Doc?
Yes. So just introduce yourself, Chimuka.
Okay. So good morning or good afternoon, everyone. This is Chimuka. This is Chimuka Sianyinda from MOH, M&E department. So I'll take you through the monitoring and evaluation aspect with regard to the pDTG. So in terms of the objectives, or what we are trying to say is that one of the things we're expected to do in this presentation is that we should be able to identify the tools we'll be using to monitor the PDD in terms of the transitioning. The other aspect we may need to demonstrate on how the children who will start on PDDT, how will be enter them with regard to smart care and also the other tools we use, such as the registers. And also my colleagues already elaborated on it in terms of the tools we are going to use with regard to the side effects and how we are going to report. And also in a nutshell, we'll also look at some of the indicators we'll be able to track as with regard to the pDTG. Next. Okay, so this is just more like a refresher of what M&D is all about. So we're just trying to say that it is a process in which the data is collected, analyzed, in order to provide information to policymakers and others for use in the program, planning, and also project management. So as you may be aware that as we will be rolling out the pDTG, we may need to get information with regard to how it's working. We have heard that we are anticipating that the issues of viral load will be sorted out. We have also heard that with regards to so many things we want to track. So yes, the program envisions some of the results we may want to see. So the M&D comes in to ensure that we should be able to see, has there been a change in terms of viral load suppression? Has there been a change in terms of other outcomes we want to track? Next. So quickly here, we just want also to remind ourselves with regard to what monitoring involves, because remember, we are just from discussing monitoring and evaluation. So we just want to bisect in terms of the monitoring. So we just want to remind ourselves that what is monitoring? So we are saying monitoring is a routine process of data collection and measurement of the progress towards our program objectives and also program activities. And we are trying to also say that monitoring involves the counting of what has been done. So in this case, for instance, with regard to the monitoring, some of the things we may be monitoring are things like counting the number of facilities would have been distributed with the pDTG. For example, at national level, be it at provincial level or district level, we may also want to monitor in terms of the number of bottles we could have received, which could have been distributed to us. Also, the number of children who could have received pDTG in a certain period time of interest. Would also want to measure or to count the number of facilities that at least have at least one healthcare worker trained in DTG. The other one, in terms of monitoring, we're also saying it's a routine process. So it's a routine and continuous process. So in this case, we expected, for example, on a monthly basis, to be able to report like what Mr. Kampamba took us through, bit on the logistical part, bit on the clinical part. We expected to be reporting, for example, on a monthly basis in terms of the number of children who could have transitioned, the number of consumables DTG who could have used, et cetera, et cetera. So just being reminded that we are expected to report on a continuous basis, and this continuous basis is is with regard to a specified period of time. So for example, we're expected to be reporting every month. So we'll be able to see the data flow in terms of our reporting as we go on. We can move on next. So again, we are just trying to say that monitoring also is the routine process, like we already mentioned that, and that the measurements of the process towards the program objectives also requires that we collect this data, sometimes multiple, meaning there are certain times when we may not get this data from one source. We may need to use another source to get this data if we cannot be able to get this data. And also what is important sometimes is that we should also be able to get the baseline where we are. For instance, in this case, we may say in terms of viral load, where are we in terms of viral load at a STEN facility? If it means the drugs, where are we at the time we are starting to monitor? The other aspect we're just being reminded is that it can be used to determine if activities need adjustment during the intervention to improve the desired outcome. So for example, one of the indicators I was trying to mention that we may be tracking, for instance, is with regard to the number of healthcare workers trained. So after this training is done, and some members of staff from PHO or the district, they go to a facility to go and check how this DTG rollout is being implemented. And we find that, for example, that at a STEM facility, there's no one who is trained. So it means that after monitoring, after checking with regard to how we are faring in terms of human resource, in terms of the trained human resource, we'll have an idea to say, with their variable resource, are we able to achieve our intended purpose? In that case, we may not be able to achieve our intended purpose, meaning we may have to adjust and train members of staff. The same thing can be said about drugs. You may have some selected sites. After monitoring, we may find that actually the facility did not even have the drugs. So in that case, will we be able to achieve our intended objectives? The answer would be no. So it may call for people to review and see how best we can implement the activities. Let's move on, Chair. So in terms of evaluation, so here again, just being reminded that evaluation is just a systematic way of assessing whether we are able to meet our objectives, with regard to the program we are trying to implement. And we are being reminded that it helps to answer some of the questions over time. For instance, we may want to find out this pDTG what we have brought on board, has it brought any change? For example, we may look at the issues of the viral load. For example, what of the children who could have been on this PDD? How is our viral load in terms of those children who would have transitioned? In terms of those who develop, who are said to have advanced HIV, what is the proportion? So it's over. So for evaluation, we're trying to check how the program would have been performing over time. The other aspect also is that evaluation appraises data and information that inform decision makers, thus improving the project or program outcome in the near future. So over time, there's 10 things we're going to learn with regards to the program. For example, we also heard about issues to do with the side effects. So we're anticipating certain side effects, which the program feels are still manageable. Then in an event with a certain side effects, we may not have anticipated, and they come on, we come to learn about them. And in case they are severe, then it may call for the program to either change so evaluation in this short, we're just being reminded that it helps us to be able to review how we have performed. So that's why such issues with regards to side effects are also very important because they also border on evaluation, because we'll be able to tell how, for example, this drug, how is it faring in terms of side effects. The other aspect we are discussing with regard to evaluation, we are saying it should help us to draw conclusions about the 5 aspects of intervention with regard to how relevant is this drug in terms of how effective the drug was, how efficient. So in this case, we are saying for effectiveness, we are trying to discuss issues. Are we able to get the desired results we wanted to see? For example, one of the desired results we want to see that we are anticipating that the issue of adherence may improve, the issues of viral load will improve. And then the efficiency, we're also trying to evaluate to say, how long was it taking for these children for example, for viral load, for them to be able to be virus suppressed. In terms of the impact, also it also give us an idea in terms of the impact with the outcome we are tracking. In terms of how has been the deaths, for example, recorded for those children who have been taking these drugs, in terms of the side effects and other things, and also with regard to the sustainability. It could be with regard to the issue of the drug chain supply. How has it been over time? Did we have in and out of stocks, stockouts? So how was the issues of sustainability in terms of the cost and these others? So these are some of the aspects which also are used in the evaluation. Let's move on, Chair. So here we're just being reminded to say, what are some of the things we normally focus on when we are monitoring? So some of them are inputs. So for example, the inputs will do with issues of finances, issues of human resource, issues of the drugs, issues of infrastructure. So in this case, we may want to check for us to be able to implement these services in terms of the inputs we need. Do we have trained healthcare providers, for example, in a certain facility? In terms of the drugs, do we have the drugs we need to use, and other aspect we may want? Then the other aspect is that as we roll out the pDTG, there are certain activities we are going to plan. So we would want to measure those activities we would have planned. Some of them would be the distribution of the drugs, the training of the healthcare workers. It would be the issue of also distribution of IC materials to the members of the public. It could be also issues of IEC materials and others. So we would want to come back and check to say, of the activities we had planned to implement, how far are we? Are we on track? Have we changed? What do we need to change? So those are some of the things we also look at with regard to the activities, with regard to monitoring. The other aspect we may have to look at are the output, as we know that output are the immediate products we could have produced. So from the activities we could have planned, what are some of the activities we're anticipating to see? We could have planned to train healthcare workers of a certain number in a certain province or district or a facility. Of those activities we planned, how many? We could have anticipated, like we had Julia Monzo was presenting in terms of the quantities we are likely to have and distribute to our facilities. So we anticipate, for example, that at a certain point in time, there is a number of children we're anticipating to be transitioned. So during the output, we want to measure. We could have anticipated that by August or by the end of November, we as a country, we should have transitioned to, for example, 1,000 children to be on pDTG. Have we done that? Where are we? How far are we from reaching our target? So those are borders on issues of output. Next. So the other aspect, we're just trying to remind ourselves that monitoring is very important. So in this case, the monitoring here, we are talking of checking of the data, technical support where people come and check how we are faring. So why is it important for people to do the monitoring? So one of the factors or the reasons we are saying that what gets monitored is likely to be done. So for example, during the presentation, we have heard, and from the scenarios Dr. Umbiana was presenting to us, we heard the different scenarios of, in such cases, what we anticipate to do. So imagine if people do not come and monitor how we are doing. In most cases, we won't be able to do what is right. So only people do what is right when they get monitored or we monitor. The other aspect why I would want to monitor is that if you do not monitor performance, you can't tell the success from failure. So like the example I was just from giving, we had the different scenarios. If people don't come to monitor and see how we are performing, if we do not get data in terms of where we are faring, it will be difficult for people at different levels to know what their subordinate institution they are doing. So that's also a very important aspect with regards to monitoring. The other aspect is that you cannot reward success if you cannot you cannot see success if you cannot reward. So we cannot be able to see a success if we're able to monitor. The other aspect that, which is also in line with what I already mentioned, that you cannot recognize failure and you cannot correct it. So meaning, if we cannot monitor, definitely won't be able to see what people they're doing wrong. And because we don't know that they're doing something wrong, it would be impossible for somebody to be corrected on what to do. For example, like the scenarios we just had, where we were asked questions and people, depending on how they were understanding them, they were able to give the response, and the facilitator was now able to give guidance in terms of where we should go and how we should be able to implement it. And also, if you can't demonstrate results, you cannot sustain support for your action. So what we may need to, what we are saying here is that, for example, it could be on the consumables, it could be on the number of children who are on who have been transitioned. If we cannot tell in terms of the numbers where we are, if we can't tell, we can't report, like what Davis was telling us, that no report, no product. So if we cannot report, how do we anticipate to get the product? So we can only report through the issues of monitoring. So if we go to the issues of evaluation, or what we are just trying to say that evaluation, like our area mentioned, that evaluation focus on what outcomes have we observed. So there are certain outcomes we are anticipating to see in terms of the provision of the PDD in the pediatric ART programming. So we want to see, have we noted a change in terms of, it could be related to the issues of viral load, it could be the issues related to the deaths, it could be the issues related to side effects, it could be issues related, related to children who have advanced HIV. So what have we noted? The other aspect we want to see is that what do the outcome mean? So of those results we would have seen, what do they mean? Have we made progress by administering these drugs in our children? Or there's been no change? Or there has been great improvement? The other aspect we may also want to see is that what does the program make any difference? For us to have implemented this program, what have we noted, for example, with regard to the issues of adherence? Has there been an improvement? So we're just trying to say that has there been any change that can be attributed to DTG in the HIV population amongst the children? Also, evaluations are conducted in order to find out what has happened as a result of the project or the program, or a set objective and also programs. Next. So we're just continuing, we're just also trying to understand that evaluation is very important. So let me just also emphasize that these points I'm mentioning, we want to be able to tell if, as facilities, we are able to document the services we're providing. It's because from those services we are providing, the people at the same level or higher level, they would be able now to start now answering to these questions I'm posing, because much of the data we are interested in terms of the outcome already in our ART form. So now the only new things will be there is just the DTG regimen combination, and we'll now be able to triangulate our data to see whether it could have had an impact. So I'm just trying to say that it also helps to understand why and the extent to which the intended and unintended results are achieved and their impact on the stakeholders. It's also important source of evidence on the achievement of the results and institution performance. That is one of the bases for corporate accountability. It is also important as a contributor to the building of knowledge and institutional. And also, like I earlier mentioned, that if you had some of the examples, like some of the side effects, it was because we're anticipating from what we would have seen in the adult population. So as we implement this, we'll be able now to tell. So then also that aspect, to quickly look at the issues of data quality. So we're saying this data we should be able to collect. It's not just a matter of garbage in, garbage out, or the issue of just collecting this data. So one of the aspects we need to look at is the data quality, where we define it as the degree of excellence exhibited by data in relation to the portraying of the actual situation on the ground, reliability and effectiveness. Or what we're just trying to say is that the data we're anticipating and expecting people at different levels to collect should depict of what is happening on the ground. And that can only happen if there are some factors we know that these contribute to the data to be able to be of high quality, which depicts of what's happening. So some of the factors we need to ensure we do that. We need to complete our data. So we should not have the backlog. For those who are using smart care, let's ensure that our smart care forms are updated as soon as possible. And we are saying for us to be able to ensure that we have got good completeness, one of the things we need to do is issues of capacity building. The other aspect is validity, meaning the data we should be able to collect should be the same whatever method we use. And what we are trying also to say that one of the important aspects that we should be able to understand our collecting tools we should be using, and also the data we should be able to collect should be consistency in terms of in an event of an outlier, it should be explained. They should be explained. We should not have just data which is just moving up and down. Also, that aspect is reporting this data timely, and we should also ensure that we adhere to our Ministry of Health reporting structure, which I'll be able to show in a while. Next. Please, can we mute ourselves? Okay, so the other aspect we also just anticipating, apart from the issues of the data quality, is that we need to be able to be reviewing, to have review meetings. I know it's one of the critical and important activity which we always do. So we're just being reminded that we need to be doing this quarterly, this monthly meeting. So at facility and district level, because we are implementing institutions, we're expected to be doing this on a monthly basis, whilst the provincial and national level, we are also anticipating to be doing that. At first, we'll start on a monthly basis. As the program stabilizes, we'll now move on to the quarterly also basis. Also, you're just being encouraged that as we do these data review meetings, it's important to bring in all other aspects of part of our administration to ensure that this activity is implemented, because at certain times, for example, at facility district level, we may have people in logistics in terms of pharmacy, our colleagues from procurement unit, whom we may also need to bring on board as we do this review, because one or another, they also affect on how we operate. So the other aspect, just being in mind that the meeting looks at the performance by province and by site-specific issues to be discussed, and also we can identify the problems that would have been identified and which also need technical assistance. Next. Okay. So these are just, it's not an exhaustive list. So these are just some of a list of the indicators which we may be expected to be tracking as we start implementing. So, so some of them is just the number of facilities which are offering DTG, the number of children who could have been started on TDG, the number of children who could have switched, the number of children who are currently on DTG, because this will be also very important as it will give us an idea in terms of how we are faring and limiting our target. The other aspect probably would be the percentage of children who could have been started on DTG. So here we'll be able now to compare of the children are currently on treatment, how many children actually are on DTG. The other aspect would be the children started on DTG who later on became suppressed. So when we start these children, after some time, how many were suppressed? Also the aspect would be of the children who were unsuppressed, how many did we start on DTG? Of those children who could have, of those children who were unsuppressed, how many, for example, did we initiate on IAC, and later on how many of those were suppressed? The other aspect we may also want to look at is of the children who are suppressed, how many actually became suppressed after being started on DTG. Also, the other aspect is we'd also want to start monitoring the side effects in terms of how many children, those who are on DTG, actually reported to have had adverse drug reaction. Next. Okay, this is just in terms of the responsibility with the issues of the data management. So the pDTG is not something which will be run independently. It will be run together with the other data, be it the HIV programming data. So it will just be part of what we always do. So as we all know that in terms of the data management at health post, we anticipate the health post in charge, because mostly we do not have the data clerks in most of our health posts. Then at health facility, health center, we anticipate that the data clerk, or it could be assistant strategic information officer, should be the one to continue the management. So like we are all aware that what has been the policy of late has been that whoever is dealing with all HIV reporting should be the same person who should report on all these. And also we are encouraging that if somebody is reporting on DTG, so if, for example, it can be in Chingola, where we have got, for example, JSISF. If we have got a staff being supported by JSISF at Chawama in Chingola, that person who is running a report for DTG, if you're sending a report to JSISF, should be the same person who should also run that report and submit to ministry. Because with regard to the numbers, some of the challenges we've been having has been that you find a person at the facility, it's the same person who runs the data, but sometimes they will run the data at different times. So for example, I need to just emphasize this point that we have been having a discrepancy in numbers at national level. So you'll find the numbers we may have from MOH, the numbers may be different from the numbers our colleagues from the PEPFAR have. And mostly it comes as a result that you may have the strategic or assistant strategic information officer. He runs the data because from PEPFAR side, this person is expected to run the data on the 3rd, for example. So this officer will run the data on the 3rd and submit. On the 15th, he's also running another data to submit to DHO. And in between the 3rd and the 9th, they could have updated some files. So at the end of the day, what MOH data will have will be slightly different from what PEPFAR will have. But the surprising thing is that the people who generate are the same people. So what we are now encouraging is that at the time, shall we mute, please? So I was just trying to set what we are now encouraging that as we prepare this data, be it for MOH or be it for PEPFAR, the same numbers would have generated at that point should be the numbers we should submit to both institutions, and not coming to generate the data at a later time and the numbers become different, because it's becoming now difficult on which numbers are we going to rely on. So I was just trying to also just remind ourselves that in terms of the data management, our officers who deal with data will continue. So at first level hospital, we do have our assistant health information officers. They'll continue with the issues of making sure that our data is in good use, our data is collected and is given to our senior people, and also we are able to transmit the higher level. The same would be said about the 2nd and 3rd level hospitals. And then at district level, we anticipate the district health information officer, and also at provincial, the senior health information officer, and then at MOH, the strategic information officer will ensure that this data with regard to the pDTG is always available. Next. Okay, so I won't belabor on this data flow because it's something we already know that we need to report this data at appropriate our designated timing, and also just an emphasis that we need to always to ensure that to implement the AAA, that is we aggregate our data, we analyze our data to see are there issues to do with the inconsistency, completeness, accuracy, and then later on we take action. If we are satisfied with our data, we should now be able So we should be able now to send to the higher level. Next, Chair. Okay, so here we're just trying to say that as you are aware that with HIV programming, more than 80% of our data comes from smart care, and only very few facilities where there is completely no smart care are the ones who are going to use paper. So in terms of the program, we use both paper and the electronic system. In this case, I mean smart care. And also what we are just now encouraging is that at the time of collecting this data, we should only use one system. So if it's an issue to do with collecting data on the clinical appointment or clinical follow-ups we could have done, we either use the registers or use smart care. But as we are aware that the primary data source for both paper and smart care are the ART forms. So the ART forms will be used as the primary data source, and depending on the system we have, we may now document in the registers, or we're able to update the ART forms in the smart care. Next. So in terms of the paper system, so what we have done for those who have attended the trainings we've had with regards to the registers we recently devised. So one of the aspects we tried to avoid was that previously, in terms of the regimen a client is on, if you go to the HIV care and treatment register, we in the past we were prescribing what one ought to indicate. But as we all know that HIV programming, there are always innovations which are coming probably every year or after another. So what we have now done with regard to the ARVs, people in the registers it's a free hand. So it's at the time of provision of a service, one should just be able to indicate the regimen somebody is on. So in this case, even if the registers have already been printed and distributed in some cases, don't worry, because it won't have an effect, because with regard to the regimen somebody's on, it's a free hand where somebody will be able to anticipate people to be just documenting the regimen somebody they're on. So in terms of also smart care, the forms should have now been revised to just also include the DTG. So it will be now easier for us to be able to implement this service. Next. So this is where I end. I submit, Chair.
Thank you very much, Chimuka. Thank you, Network, for staying on. I can see the numbers are dropping, but you agree with me that it was very important for us to also learn about the M&E. And Chimuka showed a lot of enthusiasm in sharing the M&E presentation. Thank you very much, Chimuka. So we'll straight away go into question and answer session. I must mention that I think so far we've done very well in terms of responding to some of the queries that were raised in the chat. So we'll take a few questions, but so people can actually raise their hand and then we invite them over for to ask questions. But before we do that, let me quickly just read one question that was raised. So remember, we've had 3 presentations from Dr. Simwenda. Dr. Muyana took us through the scenarios, and then we also had Ms. Siame on adherence, adverse reaction reporting, and then we also had M&E. So you can ask questions to any of this, we should be able to respond. They should be able to provide feedback. So there was an issue in terms of the use of the pDTG for PEP. I think this is open. Maybe Dr. Ziambo or Dr. Mtali can actually respond to that, and then we'll request Dr. Bosco to come through. Dr. Mtali, are you there?
Sorry, Dr. Piri, can you repeat the question?
So there was a question, I think the concern was the use of pDTG in PEP in children, since now we have the child-friendly dosing.
Wow, maybe we ask our Dr. Kiri, you can answer that one. We can ask one of our experts, maybe Dr. Moviana or Dr. Chungu.
Okay, Chungu, you are on the call. Thank you, Dr. Mtali. Dr. Chungu Chalilwe or Dr. Mubiana?
I think we can look at that as a team, a small group, and see if we need to include it and give guidance.
Thank you. Dr. Bosco, please, you had your hand up, come through.
Thank you very much, Dr. Chimuka. Thank you for the good presentation since morning up to this time. I'd written my question in the chat, but I thought this is important, and I do appreciate all the teaching. One question was about the viral load. And in the slide, it was clearly indicated that transition for the suppressed children or stable children, that viral load is not mandatory or should not be required, but is recommended. I think that's just that sentence itself. It will confuse the prescribers. If you go behind from the transition for stavudine, transition of TLE to TLD, we were having one message. I will just get the TLE to TLD, that the viral load was key. And if you check even all the case studies Dr. Mbiana presented, viral load is actually being re-emphasized. The M&D portion from Chimuka, viral have been again re-emphasized. Then we come to the transitioning of patient, we say no, viral load is required but not recommended. It is confusing. Can we speak one language? I would propose that viral load is key, because we end up transitioning patients who are failing treatment without evidence of viral load. We don't have a challenge with viral load currently in Zambia. We are getting the turnaround time at as low as 2 weeks in most of facilities, or maximum is 1 month. So that was my contribution, and I submit. Thank you.
Thank you very much, Dr. Bosco, and it's good to hear from you. That is a very important observation and submission. I'll allow another question from, I noticed Rogers, you had your question, your hand up, before I allow the presenters to respond.
Yes, good afternoon. I just had a question, not based on the presentation, but also on the logistical part, because from morning, we were having this meeting, and some of us, we don't have the internet, which is used for the facility. So like for my personal, I've been using my personal data from morning up to this time. So I was asking, is there any system that has been put in place so that people that are using personal data can be reimbursed for those it's used for the cause of work? Thank you.
Thank you very much, sir. So I now allow the team to respond. So there are two issues here that have been raised. The first one by Dr. Bosco, based on the observation, yes, I think the presenters shared what WHO recommends, and WHO actually mentioned that viral load should not be an absolute restriction or contraindications for transitioning to a better drug, in this case to DTG from the current regime. So I think the presenters also labored to emphasize that we needed to review the viral load. The last time it was done, if it's within, the latest is within 12 months and it was suppressed, we can go ahead. Absence of that, we can assess clinically, looking at the trends previously, if the child had viral load suppressed at some point, and he's been doing very well, clinically doing well, because we know some of the key salient features that points to success in the treatment for child, we should be able to go ahead and transition to DTG. I think that is the message that was shared. So there's a concern. So I'll ask either Kozia or Chalilwe to chip in. or Dr. Muyana, or Dr. Zimba? Anyway.
Dr. Zambo, thank you. Dr. Spiri, Dr. Zimba here. So the concern on the viral load. If I look at Lusaka, our biggest concern for Lusaka has been the children under 5, where our viral load coverage has been below 60%. For the above 5, and if I take just for instance for Q3 on the for this year, which is the one started April, May, June, we are at almost 90% suppression. Our coverage is around 80% for children less than 50%. But the group that is really left behind is the children below 5, which one may just be a data issue because we had a lot of children below the age of 1 who were on prophylaxis, who were picked as being on treatment. So if we remove those, our coverage goes to around 70%. So I'm not so worried about that because we'll have at least a child with a viral load that is valid within a year. So it's the issue of demanding for a recent viral load, which we've emphasized that it's not necessary. If the child has been suppressed for the last 1 year and is suppressed, they can be changed. If they're due for a viral load, bleed them for that viral load and we proceed and go on. So I think for Lusaka, we shouldn't have challenges with transitioning on that aspect.
Thank you, Dr. Zimba. That's very important contribution. Dr. It appears, is Dr. Chungo on the call?
Yes, I'm on the call, Dr. Piri, and my comment is that I really agree with Dr. Bosco and Dr. Zimba. So during the team that was working on the adult TOD transition did say that at some point viral load became a barrier towards transitioning. And I think we've noted also that like the time that, for example, there was COVID testing on the same viral load platform, there was a delay. And so I know Dr. Bosco, and I think we are all in agreement that viral load ideally should be considered, but given its absence and where you have challenges in getting viral load results, we might have maybe a child who you assess adherence is good, they have previous documentation of suppressed viral load. It would be nice to have the latest viral load on file, and it is an opportunity to do that. But then if there are challenges with getting a latest viral load, that would then disadvantage that child on being on an OD regimen, you know, instead of being on the bulky granules and might, you know, delay transition. So that was the angle from which the committee made this recommendation. I would also pass this on to other members who were on the committee who also had this thought in mind. But I do agree with you, and I think we're all in agreement that ideally a viral load should be, but in the absence of a viral load, and this is based on WHO recommending also that, you know, absence of a viral load really shouldn't be a challenge. And that's why this is where it would be key that mentorship and just support to sites should be given so that we optimize the transition process. But I do agree with you, Dr. Bosco.
All right,
Dr.
thank you.
Twaliwe. Sorry, Dr. Piri.
Yes, Dr. Maureen.
I think I just wanted us to go back to that statement. I think the statement that Dr. Bosco is referring to doesn't include the children that are virally unsuppressed. It's mainly talking about the children that are stable and they have a history of a valid suppressed viral load and also demonstrate good adherence. So for me, a lot has been covered in that statement. The viral load has been covered itself. One, the adherence has also been mentioned. And also what it also, this statement, this is the statement I think he is talking about. So the child is stable, 1. 2, has a prior history of suppressed viral load, meaning that the viral load is also covered. This child has a suppressed viral load history. In the file, you have a history of a suppressed viral load and also has demonstrated good adherence. It means that having a latest viral load result should not delay switching or transitioning. So what it means, I'm just going to give a practical example. If I have this child who has come today and say is at 9 months from the last viral load, and when I'm looking at the last viral load and it is suppressed, I'm not supposed to look at the next viral load, which is due in 3 months, and say, let me wait for that next viral load. I'm looking at the child here has demonstrated good adherence. I have a viral load which was done 9 months ago and it is suppressed and the child is stable. What do? I transition this child. This is what this statement is talking about. It hasn't overlooked viral load. The viral load is still key and is also mentioned in this statement. And this is basically for the stable child. When it comes to the unstable child who is unsuppressed, we did mention that definitely we have a history, this child is unsuppressed. Let us put this child through EAC. That is what we mentioned. So we're not overlooking viral load in this statement. There are different scenarios that people will come across. So we don't want a child coming at the 10th month, due for viral load in 2 months, then I say, no, let me wait for the next 2 months until this child is due. So I'm just emphasizing that we are not overlooking viral load in this statement. So different scenarios will come through. Thank you so much.
Yes. Thank you very much, Dr. Smwenda.
Dr. Chimuka.
I'm Dr. Chimika. There's Chimuka already here. Dr.
Sorry, Dr. Chimika, sorry. I just want to recommend Dr. Maureen for this clear emphasis. And, you know, this is a public health manual or slide or recommendation which will go far as Mumbachala. And Mumbachala, they should know, even when we say history of suppressed viral load, let's say history of valid suppressed viral load, because history of suppressed viral load, you might take it that the viral 5 years ago, it is too suppressed. But if we are concise to say history of valid viral, which will be in bracket within 12 months, that patient should be transitioned. So that was my emphasis, and thank you for all the contribution. Thank you.
Thank you very much, Dr. Bosco. So I think we still need further, this actually calls for further capacity building, trickling down the facilities through various teams such as mentors and other people. So I know this is just the beginning. So this issue we need to explain further down, and so that there's no confusion. Thank you very much, team. This is 7 minutes before 13. Maybe we can just allow last 2 questions. I can see there's a hand from CRIS, Leja Lito. Please come through.
Thank you, Doctor. Good afternoon. Just a follow-on question based on what Dr. Maureen has just said. So let's say this child has 2 months to go before the next viral load, and then I switch them to pDTG. Do I go ahead and do this viral load as scheduled in 2 months' time after being transitioned or being put on pediatric DTG? That's the first. And then the second question would be, and then you get the result of this child, and then it happens that the child is not suppressed. What will be the next step of action? Thank you.
Thank you very much, Lejo. Dr. Maureen, do you want to come and would you want to respond to that?
Yes, so that's why I'm saying that the clients will present, I just gave that scenario. The clients will present differently. The scenario you have talked about, and that's why it's good, it's always advisable to look at that client in front of you. So at the 10th month, a client comes in, you haven't specified the age. It could be of any age. If I told a client, and I put 9th month because I'm looking at a client who probably has the next visit in the next 3 months when the viral load is due. Okay, I just mentioned 10th month. So now you have to think of when is the next visit for this child? Is the next visit next month? If the next visit is next month, why should I say come next month for the viral load test to be done? I need to do it today. I'll do it today, isn't it? So that the child doesn't come back. Definitely. So it all depends on what you have at hand. When is the next? A lot of things have to be considered. Okay, I'm seeing this client. When is the next visit? Is the next visit next month? Let me do the viral load today so that the next visit, is the next visit in 3 months? Let me do the viral load today so that the child, when they come in the next 3 months, they find the VL done. So at the 10th month, please determine when is the next visit for this child. Okay, is it in 2 weeks? Is it in 3 months? Is it in 6 months? So if it's in 6 months, let me wait until the 6th month when the child is due for viral load, because this viral load they have is still valid. So let's look at all the angles. Let's bring together everything that is happening. So at the 10th month, you are seeing the child, all right? When do you want to see the child next? If the child is going to be seen in the next 3 months, is the child going to be seen in the next 6 months? Depending on your drug, the supply that you're going to give the child. When are you going to see this child, follow up the child? So other than what is happening, what we have mentioned, also look at when is the next visit for this child and when is this child due for VL? I hope I'm clear, because the scenarios will be very different. If I mention what you have said, I can give an example. 10th month, I'm seeing the child. I want to see this child in the next 3 months. I can wait and do the viral load. But if I want to see the child next month, I can do the viral load now. So I think it depends on the scenario, and that's why we really have to individualize this management of clients.
Thank you very much, Dr. Smwenda.
Dr. Chimika. Dr. Chimika.
Please, let me just finish what I want to say.
Okay.
I'll give you a chance. Yes, so thank you very much, Dr. Smwenda. And I think what is important is that these guidelines do not replace us thinking what is to try to be done to a patient who is in front of us. So it's just a guide, and patients come different with different challenges. So as she mentioned, we need to look at each case individually, and we need to consult where we are not able to, we may not be able to do or to know what to do next. So especially in children, some cases may be a bit complex, so let's consult. So we can discuss different scenarios, but what is important is what Dr. Smwenda mentioned, that these children come with different individual challenges or scenarios. So we need to make sure that we consult. So before I invite, I think this was Hargreaves from Cinder. Before he comes in, there was an issue. I think this is more administrative. I don't know who's going to take it up. Dr. Mtali, there's issue about reimbursement of bundles that have been used by individual people. Are concerned that they've used their own individual bundles to participate in this activity. What has been planned for that? Is there anything?
Oh, yes, Dr. Piri, thank you very much. And we just want to thank everyone who has joined in and those who've used their bundles. You know, the support will be given to the provinces as they scale down the trainings to their facilities. Unfortunately for this training, the bundles will not be reimbursed. Sorry for that.
Thank you very much, Dr. Mutali. This is 13 hours dot. There's somebody who, was it Cinda? I believe, is it something in relation to what we've discussed?
Yes, Dr. Chimika.
Oh, please, kindly be brief so that we close.
Yes, I thought Dr. Eleda's question was not addressed, because this question was, I see a child today, which is the 10th month, and then I want to see the child in the next 3 months, and when they come back, they are due for a viral load. We collect the viral load, they were switched to the DTG. So after 3 months collecting the viral load, that viral load comes out high. What next? I think that was the question, unless I didn't get him right.
Yes, so that is one of the scenarios. And I think Dr. Simanda mentioned that we can cite different scenarios, but we need just to discuss as clinical team what is next. So there are guidelines. So that one, remember looking at, we've just switched this child to a new regime where I've added DTG. And we know that DTG, based on the observations and study that is shown, within 4 weeks, somebody should be able to achieve viral suppression. But 3 months later, this child, the viral load is still high. So you can give child the benefit of doubt and to say, is it that the drugs are not working, or is this issue about adherence? So you review case by case and discuss. And then there's the standard where if the viral load is very high, you can still enroll in EAC. That hasn't changed. So we can give different scenarios. So, but I think the broad answer that we can give is, let's discuss with the clinical team if we have such challenges where we are not sure what to do, then we should be able to guide, because there are a lot of things that we need to evaluate and look at before we cannot give one answer that will be the right answer for all the scenarios. So I thought she had touched that part when she gave when she mentioned that we need to tend to individual patients as an individual, because they'll have different challenges. Okay, so in the interest of time, I know this has raised a lot of important discussions, and I know people have very important submissions. How I wish it was the whole day, but remember, people are using their own data bundles. So, and it's 13 hours. Allow me now to invite Dr. Mutali to say the final remarks and close the meeting. Unless Dr. Chung, we want to have something before Dr. Mutali comes in.
No, Dr. Piri, nothing from me. Thank you very much.
So thank you very much, team. I really enjoyed chairing the second session. This has been a very interactive orientation. So I now invite Dr. Mutali, who is our national coordinator for pediatric HIV, ART.
So thank you very much, Dr. Piri, and thank you to the network for that active participation. I believe that everyone has gotten the information, but I know from the discussion, we still need a bit more orientations and a lot of mentorship, and just a bit of the way forward. So the provincial health offices will be requested to train, or are expected to train, the districts and the facilities, especially those that are in the first phase of the transition. And we must emphasize that looking at the time, they will need maybe a whole day so that they do practical demonstrations and emphasize on the weight-based dosing. And also they will look at scenarios, different scenarios like we've done today with the transition challenges. And therefore, even all those who are on this call today, depending on when your provinces will be trained, you will still participate in this training. So if there are still any questions, please reserve them and we'll raise them up in the next trainings. So it has been emphasized also that we need to do active pharmacovigilance. This is a new commodity, and therefore we want to gather as much information as possible. A presentation was made, and therefore we expect people, if you have questions, please feel free to ask either the presenters or the committee that sat to do this. We'll share the addresses, we'll share the phone numbers, and also, your provinces and your districts. And this is a new product we keep emphasizing. And therefore, we need good reporting so that we know how much, how much commodity is there, how much we are using, so that we monitor very closely our stock status. We don't want we don't want to overstock or stock out of these commodities. And then the commodities themselves, the distribution schedule is being worked on. I'm not sure if it has been finalized or not, but definitely it's being worked on. And it will be shared with the provinces and the district pharmacies, and all the information that is needed will be communicated, especially to the facilities that are in the first phase of this rollout. But then I think we must all move with caution. Pediatric DTG is not like a magic bullet that will sort out all our problems. Please remember all the other important issues should be looked in, especially the weight-based dosing, adherence. We have obviously linkages, family-centered care, everything. Let's not forget, because if we forget everything else, even our DTG will not sort out, and we might even lose the DTG that we are so excited about. So please, let's not forget the other issues in the program that are important for us to have good outcomes for the children. And I think I've already mentioned, let's keep communicating with the provinces, the districts, and we have the ECHO platform, which is a very good channel, and it has helped us a lot. And my appeal to the partners is that please, let's support the regions that we are supporting in the data bundles issue, so that all the trainings that we do run smoothly. Let's not forget the mentorship. Without mentorship, we won't have so much success in the good outcomes that we are expecting. And last but not least, we have our communication channel, the 7040, which is a 24/7, facility for us to communicate. If we have any challenges, and as we start the rollout, we expect that we'll have a busy time at 7040 because of all the questions that will arise already from this orientation. There are so many scenarios that if we could go through them, maybe it would take us a week to complete them. And therefore, let's keep them, but let's keep asking so that we are very sure of what we are doing. So all the documentation that is needed, the training slides, the schedules, the facilities will be shared with the provinces, the districts, who will in turn share them with the facilities. So with that short way forward, I would like to thank everyone and close this meeting. Thank you very much.
Thank you.